Rudy, you are still muted. You have to push the button of the microphone so we can hear you. Just to check.
Yeah.
Yeah, excuse me, Pablo, you ready to put the
Now we can hear you.
Yes,
Okay.
John.
yeah,
Thank you.
we're
Hello,
just
everyone.
gonna try to connect this to YouTube. Go ahead, Pablo.
Hi, Pablo.
Yeah, I think it's working. Can you confirm, John?
Okay, did you put it on my account?
No. Finally, I made it in hours.
Oh, good, good. Let me check.
Pablo, why don't you make a picture? Make it.
Which picture? Ah, Pablo.
A group picture to start with,
Group
because
picture.
most of the time we do it at the end and half of them disappear.
And
Okay.
Igor,
Igor, hello.
good afternoon.
Okay, okay, Pablo, got it.
thank you so much, John. Thank you.
Have a good one.
Bye-bye. Thank you.
For the program today, there will be some minor changes. I think Dr. Landero from Brazil, he asked me to put him on the second half, second sessions, as he has a flight to catch up. So he will be arriving from the airport, so we will defer his presentation for the second session. And Lucas from Serbia, he changed his mind. He will be on time for his presentation because earlier he asked to be early. He has a clinic, but he will be on time.
I guess changes in neurosurgery are inevitable.
Yeah. So we are talking to flexible people. We try to be as flexible as possible. In 2 minutes, we will start soon. And we have sent correspondence that we'd like to finish when possible. Never happened, but when possible, to finish on time. And we ask each speaker to have 15 minutes presentation and keep few minutes, up to 5 minutes, for some questions or comments, some interaction, because this is where the value of the whole webinars. And I hope everyone is agreeable to this one.
Yep.
Yep.
Takashi, good to have you.
Good evening.
So,
good evening.
Good evening.
Yes.
What is the time in Tokyo now?
Now 9 p.m.
9 p.m. Okay.
9 p.m.
So you will stay to the end of the webinar. It will be
Yes.
2 p.m.
Yeah, 2
2
p.m. Yes.
2 a.m.
I'm eager to join.
Thanks for joining.
Thank you.
So on behalf of the newly established Academy of the International Academy of Neurosurgical Anatomy, a continuation from our previous activities with the World Federation. So we'd like to continue this educational webinar and activities to teach young generation around the world, joined by the president of this society, or this academy, Vladimir, and Professor Brodsky, and the members, and the distinguished guests. They kindly accept to give the time that has a special meaning for the second webinar, recognizing and honoring our colleague that we miss him tremendously, Professor Fred Gentili, and his life achievement. It has been now amazing how time flies, 3 months ago. I was talking to Gina, his wife. She is very appreciative to all of you that you still have him in your heart and in your memory. And God bless his soul. Now I think the first sessions will be shared with Professor Poggi, Professor Pablo Gonzalez, and myself, and I will be starting to introduce the first speakers. And I think I remember how much Fred was very keen to talk about esthesioneuroblastoma, and Thomas Santerius from England, he's going to talk about the anatomy and modern management of esthesioblastoma. Thomas, it's all yours.
Thank you very much. Yeah, now I can share. And hopefully you can see the slides now.
Yes.
Yes.
All right.
Okay, so Fred has always been in the forefront, at the leading edge of neurosurgery in his field, and I'm sure this meeting will provide ample evidence for this statement. I'll start with the first piece of evidence talking about olfactory neuroblastomas, previously known as esthesioneuroblastoma and many other names. And I have sort of this sort of fantasy or picture which is supposed to illustrate forefront of neurosurgery, and this is old anatomy. And Fred has been one of the first ones to adopt endoscopic approach to esthesioneuробlastomas, and indeed this is one of the first series published on this subject, and I read it with great interest, and Fred has always been very inspirational. But Fred has always been firmly rooted in anatomy, and this is in 2009 when he came to Cambridge as a guest speaker on this meeting, and here he is engaging with lots of young people and more established neurosurgeons. We have all learned a great deal from him, and we are very grateful. And if you look at the program from the 2009 edition of the lectures, Fred Gentili, Evolution of Skull-Based Surgery, Lessons Learned, and Quo Vadis. So he was always looking to learn from the history, and was always looking forward. And he was always keen to evaluate, and that's why kind of slightly inquisitive look forward. Always look backwards, evaluate before you go forward. Therefore, for him, there's never been a conflict between anatomy and leading edge of neurosurgery. It was always going hand in hand. Unlike this Thomas here, who is very happy to enjoy his ignorance, Fred was following this statement that risk comes from not knowing what you're doing. And so let's define what neuroblastoma is, olfactory neuroblastoma is. It is, of course, very rare, and invades locally, but also can metastasize. And most importantly for us, the degree of resection, in other words, free margins, are very important for survival. And it's been known since the 1970s, where very aggressive surgery was developed. Now, when we talk about endoscopic techniques, we don't mean that they are less aggressive from the oncological point of view. One way or the other, the surgical aim in the past, now, in the future, unless we have some sort of magic treatment, is complete surgical resection with negative margin. So let's think, where does the olfactory neuroblastoma arise? It arises from the olfactory epithelium, which is located in the lateral nasal wall, nasal septum, superior turbinates, sphenoethmoid recess, and upper part of the perpendicular plates of the ethmoid, and also from the cribriform plate itself. So let's understand this. Let's take an opportunity and understand the anatomy of the region a little bit. So essentially, in the olfactory epithelium, we have the receptor cells, which are the cells that bring the olfactory information into our brain, which are supported by the basal cells. And then eventually the dendrites of the receptor cells then go into the olfactory bulb, where it's beyond the scope of this talk to analyze this in greater detail, when there's synapse and then dendrites of these cells run in the olfactory tract. And here it is kind of a little bit more schematically, olfactory bulb, olfactory tract, and here are these olfactory filaments. And olfactory filaments are the groups, bunches of this philia of the receptor cells. There are about 20 of them transgressing the cribriform plate. And this is what it looks like from the top when in the cadaver, when the anterior skull base is covered with dura. You can see the cut olfactory tract with the olfactory bulbs inside the olfactory fossa, and this is crista galli. And when we remove the olfactory bulbs, we can see the holes through which the philia transgress. And this is when we remove the dura, we have the bone, and we can see that we actually have two bones articulated in this area, which is the frontal bone and the ethmoid bone. So it's ethmoid bone from the lateral. And you can see the smooth part of the ethmoid bone called lamina papyracea, which is facing the orbit. And so we need to keep in mind that essentially the ethmoid bone is made of the perpendicular plate, which forms inside the nose, the nasal septum, the upper part of the nasal septum, and intracranially the crista galli. And perpendicular to it is cribriform plate, and lateral to the perpendicular plate are the ethmoids, which we will talk about a bit more later on, and they articulate together like this. So if we flip the ethmoid bone onto the frontal bone, they form the ethmoid L cell as we know it. So the frontal bone forms the roof of the ethmoid bones, and often we use the term fovea ethmoidalis. Fovea means pit in Latin, which is little hole in the frontal bone here. So that's what it looks like when it articulates. And again, some sort of terminology to be clear about. So that's again crista galli, the upper part of the perpendicular plate, and then the roof of the nose inside the ethmoid bones, the fovea ethmoidalis, which, as you know now, is a part of the frontal bone, and a bit more medially, the roof is formed by the cribriform plate, which is part of the ethmoidal bone, and this bit is called lateral lamina of the middle turbinate, which we will talk about a bit more later on. Yeah, I'll just leave it at that here. Vascular supply, we will be talking about the anterior and posterior ethmoidal artery, both branches of the ophthalmic artery coming off of the orbit and then entering the skull base and giving off meningeal arteries, and again diving into the nose, supplying the mucosa of the nasal cavity. And that's again what the anterior and posterior ethmoidal arteries look like. The anterior ethmoidal artery runs in the anterior ethmoids, posterior ethmoidal artery in the posterior ethmoids, and here you can see the course from the orbit into the intracranial cavity, again from the orbit into the intracranial cavity. Again, talking in the great detail about it is beyond the scope of the talk. And this is kind of the old-fashioned procedure, again on the cadaver, to identify the anterior ethmoidal artery. Of course, we would never perform such a large incision, because we need to be between the between the lacrimal sac, which would be located around here, and the trochlea. We can't damage them, and that's how we can ligate either electively or even in the case of emergency anterior ethmoidal artery. And anterior ethmoidal artery is located, it should be 24 here, more or less 24 millimeters from the anterior edge of the frontal bone. Again, it's very important to know for this sort of surgery, all sorts of reconstructive procedure. Now, I would refer you to many good articles that have been published, and this is one of them, which I personally found quite helpful. Again, it's beyond the scope talking about it. I will instead take you through an illustrative case that was done by my colleague, Rishi Sharma. It's a part of the Cambridge Skull Base team. It's a 37-year-old man presented with loss of smell and taste over many months, and on endoscopy there was irregularly shaped polyp found in his nose, and it was biopsied, which showed olfactory neuroblastoma. So we had elective surgery for it. So this is what it looks like. There's pretty much nothing here. Then you can start seeing some sort of mass which extends posteriorly pretty much to where the olfactory epithelium is. And this one was judged to be good candidate for endoscopic. Pretty much we all do them endoscopically, sometimes supplemented with transcranial procedure, particularly if complex reconstruction is carried out, but we aim to do it all endoscopically, achieving clear intraoperative margins. So the first step is intranasal debulking of the tumor. These are the sagittal view of it, and this is sort of video showing. You can see the irregular shaped polyp. Even if you haven't seen any of those before, it is pretty obvious what the tumor is. So it is debulked, and when this is done, this will uncover a bit more sort of recognizable anatomy of it. You can see the middle turbinate here. Then the circumferential exposure of the skull base. So basically full removal of the ethmoid bones, anterior, posterior, skeletonize the orbit, essentially keep the clean periorbita. In this case, we expected that the tumor would not be involving the orbit, and indeed it wasn't. It of course involves the upper septum and posterior septum, so you need to do septectomy and expose the planum, remove eventually the planum cribriform plate and the fovea ethmoidalis. Again, in this case, we didn't expect to involve a brain. So these are the steps schematically. Again, a little bit of a video. So middle turbinate on the left moved medially. That's the axilla. That you can see, just you had a glimpse of the sphenoid ostium, and essentially keep removing things bit by bit. So now, of course, you need to resect the middle turbinate, and then that's just done here. You can see that it's diseased. That's kind of the base of the disease, and is not surprising because we know that even in a relatively non-extensive tumor, it will be involved because that's where the tumor is known to arise from. Septectomy, of course, we need to remove the septum. In some cases, the contralateral nasal mucosa can be used for reconstruction. In this case, it was all involved, so we removed the entire septum, so it was not possible to do nasoseptal flap. So septectomy, actually we skipped that because it's pretty straightforward, and in the interest of time, opening of the frontal sinus, identification and ligation of the anterior ethmoidal artery. That's why we need to know where it is, and ligation of the posterior ethmoidal artery. You can see it's been identified here. That's the remnant of the tumor coming from the cribriform plate. The reason it's important to ligate this artery so that we can then separate and move the periorbita and the orbital contents laterally without the risk of the artery avulsing and then bleeding into the orbit, perhaps unrecognized post-operatively. So the periorbita can now be mobilized and just move laterally. You can see that's the left periorbita is double secured, bipolar, secured with bipolar coagulation for the reason I outlined before. Then we just do the skull base cuts that we discussed before, essentially through the fovea ethmoidalis on either side, and this is then the cuts are pretty much done with drill, or depends what it is like. So that's the drilling the fovea ethmoidalis on the right side, then we'll drill the fovea ethmoidalis on the left side, and essentially you can see now the dura of the olfactory fossa, which will then cut with a knife later on, and essentially here we go. That's
Thomas. 2 minutes left. 2 minutes.
Sorry.
There's 2 minutes left for this activity.
Yeah, I'm pretty much done. So this is the dura in the olfactory fossa. We cut it and then have a clean brain at the end. In this case, it was not involving the brain. The reconstruction was because we didn't have vascularized flap, of course, because we had to remove the bilateral mucosa of the septum. So we used free flap with Duragen and fascia lata, supported with a scaffolding. And this is post-operative image, and the margins were confirmed to be clear. I'd like to acknowledge that I've used some pictures from the Gray's Anatomy, and of course our great teacher, Dr. Roten. And again, I've learned a great deal from Fred, and he will always remain among the greatest people I met in neurosurgery. Thank you very much for your attention.
Thanks, Thomas, for being on time, and it's wonderful anatomical correlation to handle the old name esthesioneuroblastoma, now olfactory neuroblastoma. We'll have a chance to have some comments, one or two, or some questions. Ramesh from England.
Yeah, thanks, Imad. Tom, I missed the first part of it, but do you send frozen during the procedure to verify the margins are clear or not?
Yes, we do. That's the cornerstone of what we do. We really want to end the surgery with intraoperative known negative margins.
Yeah, thanks.
All right. Any other comment or questions? Yes, Rodo.
When would you indicate a transcranial operation? Because the cases I've seen, they have a major involvement or invasion of the frontal lobes. And we, in these cases, start transcranial and do the endoscopic work at the end. Your comments, please.
Yes, thank you very much, Professor Falbusch. We do transcranial approaches exactly for the same reason you mentioned. Also, in a relatively rare cases when there is a very lateral spread of the tumor, where you will have to go around the orbit, so to speak, which often is out of reach of the endoscopic approach. Sometimes when also the anterior skull base is very broad and wide and the opening is massive, we also go transcranially to essentially perform a better quality repair, particularly using vascularized flaps. I didn't have time to go into details of that, but of course, reconstruction of the anterior skull base is a major issue in any operation, including this operation, where the opening can be extremely extensive, not only from left to right, but also anterior posteriorly. There is no better reconstruction than using vascularized flaps, and ideally local vascularized flaps rather than free flaps. But that's another lecture in its own.
Thomas, another comment that people keep asking about it, judgment of the resection with margin, how you take going from above versus from below.
That's pretty much what Professor Falbusch mentioned. When the brain is involved, particularly laterally, and if the dura is involved very laterally, where we will have to go very much behind the corner with endoscopy. I mean, to an extent we can go, but it's important to have all the tools to your disposal and keep the main aim of the operation, which is complete resection with free margins, and whatever way we achieve that. But it has to be achieved. So, I wouldn't be this kind of person who has one technique. That's why we have a team of very experienced endonasal surgeons and neurosurgeons that we throw everything at it so that every case is perfect at the end.
All right, well, thank you very much, Tom. I will move to the next speakers, Professor Pablo Cababianca. Very well-known neurosurgeon, and he set the guidelines for endoscopic surgery on the pituitary and the contemporary practice with his famous publication with the Vitis. And he's going to talk about anatomy as a key for innovation, and I think very attractive title. Pablo?
Thank you very much for your invitation and to have me remembering an old friend and an excellent neurosurgeon. Our experience has gone through, I would say, many steps. Okay, and we get lessons from many of the things we are doing, and trying to orientate with strength and creativity, which is not always easy. And I would say that lesson of neurosurgery and lesson on anatomy enables starts with Francesco Castellano. All of you remember meningiomas of the posterior fossa, and you see him studying anatomy with the neuroradiologist Giovanni Ruggero in Stockholm in the early 50s or at the end of the last 40s. And it's important. It's important education for us neurosurgeons. It's important also in these difficult times. This is a picture of a contemporary artist which is leaving his country with a computer to work with. And in the field I have been working for the last 25 years, there are, I would say, forerunners like Gerard Guyot, who started using the endoscope, Michael Apuzzo, who saw what we would have been doing years after he wrote this paper. This is the way we go through, and these are the groups, Italian groups working, and also Castelnuovo and Locatelli have done a very good work on neuroblastoma and on the reconstruction we have been talking about. But the work of neuroanatomy starts centuries ago. This is the anatomical theater of Padua. This is a picture I've been given by Manfred Chabischer in Germany, Anatomia Clavis et Clavus Medicinae. And anatomical dissection is the key of our work. And there is not, we need to know anatomy, irrespectively what we do in our work. We can be anatomists like Manfred or otolaryngologists like Paolo Castelnuovo. The key is perfect knowledge of anatomy, because anatomy, first of all, needs helps in investigating what we are going to do, comparing with different pathology, and have been evolved with measuring our attitude to perform surgery. We have done many studies like other groups, and we have also given many workshops to work with other surgeons to teach and to learn from them. We have done also immersive weeks to deep our knowledge about it. And just recently we have started a master of second level to teach new generations this kind of work, which goes through simple steps, nasal, sphenoidal, and cellular, knowing perfectly the lateral nasal wall that we were not used to know some decades ago. And we need to stay oriented in the midline and outside the midline, because before damaging structures that most often are on the lateral aspect of the approach, we need to know where they are and to prevent the damage. We need to know the way we go through the sphenoid sinus with the different anatomical aspects. And this is the door, like in San Francisco, where the big generation is I am the door. It was written on city light books. This is the door, the entrance, with the cellular floor and the clivus and planum sphenoidale, carotid and optic protuberance, the optocarotid recess, which give the access to this magic structure that's the pituitary gland and the pituitary stalk. And this kind of surgery has proven to give many advantages for the wider and look close to the relevant anatomy, and also the possibility to expect hidden corners. This is the reason why, after working on the pituitary, the horizons were enlarged, and we could make also innovative exposure of the cranial base, which had already been conceived years before, with seeing the anatomy, which is just the same as seen from above, but under a different perspective. And this is an anatomical preparation of an extended approach. There is the possibility to have many multiple surgical models, and these are the transcribriform approach, the transtuberculum approach, which we have studied from below and given the name of suprasellar notch to the tuberculum cell, because from below has a different aspect. It's not a protrusion, but an indentation. And then come the intradural areas we can work on with the 4 different areas: suprachiasmatic, subchiasmatic, retrocellular, and ventricular. And inside the ventricle, there is these are the 4 areas I've just shown, and ventricular. And inside the ventricle, 4 areas again: infundibular, foraminal, mesencephalic, and tectal. And I'm going to show some anatomical specimen we have had the possibility to know before working on the subject. That's very important. We didn't try not to learn on our experience on the living patient, but on the anatomical specimen. And you see also the cavernous sinus approach. The School of Bologna, with Giorgio Frank, has done a great job. And it goes all around the carotid, but with the possibility, from the nasal perspective, to work with the medial and the lateral corridor, with respect to the biology and anatomy of the lesion. We have not to do everything we would imagine, but just to do what is possible and where we know that it's possible to work safely. And there is the transcribal approach. Today, the chordomas are approached almost all through this approach, if not the lateral extension is present. And you see, it's a nice, this paper that gives the rule of three, the third, the sixth, and 11th, 12th cranial nerve going from above to below. And Dr. Apuzzo has just told us that with the deep knowledge of anatomy, more science than art comes in our work. More science giving standardization of the approaches, increases safety, better outcome of the patient, and not surgery for the virtuoso only, as we heard in a very nice presentation in 1979 at CNS by Ivan Ciric. And the lesson of anatomy keeps going on, because today we have three-dimensional computer-based models to study anatomy. We have the possibility to know the working area where we work on, not only are able to see, but to work on the surgical target, the so-called surgical freedom. And working with all these aspects, together with the anatomists, together with the neuroradiologists, we are making further steps. Radiomics, today or tomorrow, we will not only be able to know which pathology are going to face during surgery, but also there will be is coming the possibility to have prediction on the biology of the lesion. So we will have a preoperative pathological diagnosis with prognostic stratification, the kind of treatment that we are going to give to the patient, and even genetic and phenotypic structure of the lesion. It's necessary to have a teamwork to be able to do this kind of surgery, and that will give us great possibilities for the patients. Thank you very much.
Well, thank you very much, Paolo, for being even shorter than the expected time. We were giving you another 5 time. Well, it gives us an ample time to discuss and have some questions. And the talk is open for comment and questions. Please, whoever feel. I have questioned myself, how do you see the evolution regarding equipment for endoscopic surgery as compared 10 or 15 years ago and now? Are we moving in the right direction? Are they a dynamic on that aspect, or we are still obliged to use some of this equipment that we need to have some additional in the horizon as an innovation?
I thank you very much for your question, because I was just discussing with my co-workers, Dr. Cavallo, Dr. Solari, because I have another presentation in the next days, and I included also the study, the progress of equipment, because many of us, many of you have contributed with some instruments. I have seen in the former presentation of the colleague from England that there was the use of XOMED, and so on. There are many simple and engineered tools that we have worked with, created, modified, and this kind of work will continue because surgery is going on, and the requests of very precise and good surgery are still present and necessary.
Giovanni?
Yes, one question, Paolo. Wonderful presentation. And just one question for the young people that are starting. The old problem, older or forehands surgery. In your huge experience, what you will teach to young people?
You mean also microscopic or only endoscopic?
No, endoscopic. Older for endoscope or forehands surgery?
No. Forehands surgery, because it's more dynamic. I think that when you work with some of your co-workers, you become just one surgeon. You know what you need from him, and he knows what he needs from you. So I don't favor the use of the older. No, just forehands. Thank you.
I have to give a comment to Paolo that your book on endoscopy becomes the holy book of the endoscopic neurosurgical religion, because we all refer to it. It has a marvelous anatomical landmark that shows, and the cadaver as well. Any other comment or questions?
Ahmad, I thank you. But
Professor Falbus?
Yeah, thank you, Paolo, and congratulations to your continuous work. My question goes to anatomical variations. How far are you teaching this also? And your comments on the center area, for example, the changing distances of cavernous sinuses and carotid arteries. Is this a very important part to speak also about variations?
Yeah, no doubt that today we can know much more before surgery than in the former times. So we can analyze and study in detail before surgery what we are going to do. So progress is also this, the use of many tools, neuronavigation and simulation. We can add to our daily work also other contributes that I think that for us are just contributes, but there will be daily work, daily tools for our young generations.
If I may comment here, I absolutely agree with that. And I think it was a very important point Professor Falbus has made, that there's a great variation and variability, particularly in this part of the body. And as much as various studies which give us average distances and relationships, it is more important to know the principle of these relationships. And then, as Paolo said, we need to study the, with all this knowledge, we then need to study the imaging for that individual case so that we can understand it and keep an open mind about the very specific relationship in that particular patient.
Thank you very much. And it's so important what you say, and Professor Falbus pointed out that sometimes just 1 or 2 millimeters make a great difference in the approach to the target of that subject. You understand that if you had done 2 millimeters more, you could have worked better and so on. Absolutely.
All right, so I like to ask Professor Giovanni to take over the mentorship or moderation and present the next speaker. Giovanni.
Okay, thank you. The next speaker is Schroeder. He will again give a lecture on the endonasal approach to suprasellar craniopharyngioma. Henry.
Yeah, thank you, Giovanni, for the nice introduction. Thank you, Imad and Vlad, for the invitation. I'm very happy that we dedicated this webinar to our friend Fred. And everybody knows him. He was a really charismatic surgeon, a very good teacher. I have known him for 10 years. He was a special guest at our endoscopy course in Greifswald in 2016. He was an excellent teacher. He traveled a lot around the world to teach young people in endoscopic endonasal surgeries. And he also enjoyed the life. That was also some fun. His marvelous wife, Gina, she organized a lot of social events at different meetings here in Venice or in Berlin. And Jacques wrote a very nice obituary about Fred. I read it with interest, and he is completely right. It's a great mess were his slides, so crowded with a lot of information, so many colors. And it always was fun to discuss with him, because he always wants to have results, not only nice videos, but also he wants to see what is the outcome for the patients. So one of his major topics, or lovely topics, was craniophangiomas. We discussed a lot about it. So the main question is always, should we aim for gross total resection? And we always said, yes, if it's possible, we do it. But if we see here there's infiltration of the hypothalamus, it's ill-advised to do it because it may destroy the patient and his function. Next question is, should the stalk sacrificed? And you know, even if you preserve the stalk, it does not necessarily result in a good function of the stalk. And this paper from Ted Schwartz shows that 50% of the patients where he preserved the stalk did not work. So finally, there's only the risk of recurrence. And that's why there is an editorial of Oldfield. And he said, if the infiltration of the stalk is the only reason why not a gross total resection could be achieved, then he advised to cut the stalk because it can be replaced with hormonal therapy. But you have to consider in which country you are. I was once in Bangladesh for a course, and then the doctor said, please don't sacrifice the stalk because the patient cannot afford the medication and he will go home and will die finally. So this all has to be taken in consideration. And there was one paper interesting from a Japanese group. They were very aggressive with resection of the stalk and even the floor of the third ventricle. And they said, even if they cut the stalk, they had 50% of patients where the stalk function is regarding DI was reservable. So the DI recovered. That is very interesting because on all of my patients, if I cut the stalk, I never saw a recovery of the DI. So what is the best approach? When we saw these tumors previously, you see this is a typical suprasellar craniophangioma. This is the chiasm, so we have a prefix chiasm, but nevertheless, always our standard approach was pterional. And then you see there is no tumor visible. You see this is a chiasm, this is a carotid, so we have only the retrocarotid window, or we make translamina terminalis approach, but the tumor was not very well seen. And this caused in some patients visual problems. When you have the endoscope, the big advantage is we look directly to the tumor, we can identify the stalk very easily, and we see the suprahypophyseal arteries very early. So all these can be preserved because we see it, and the chiasm is above, and we don't need to manipulate it. That is a big advantage. That's why for craniophangiomas, which usually cause a prefix chiasm, for me, this is the ideal approach if it is a midline tumor. There's a nice classification of CASAM showing 3 different types: pre-infundibular tumor, transinfundibular or intrainfundibular tumor, and location behind the stalk, the retroinfundibular tumors. And this is of value because in the pre-infundibular craniophangiomas, we have the best chance to preserve the stalk and have a gross total resection. So when we open the dura, we just see a tumor. Stalk is hidden behind or on the side. One example, a patient with bitemporal hemianopsia and visual loss, visual acuity decrease on both sides, very severe. Yes, a small tumor looks the same like the case I showed you before. Again, here is the prefix chiasm. Yes. And there is, of course, now the better approach to come from below. So this was my first case of suprasellar craniophangioma, which we discussed. We waited surgery. You see this pituitary gland, optic nerve left, right. arachnoid is open. You see the branches of superior epiphyseal arteries. So first we decompress the tumor, and then you see with an HD technology, you have such a good view and you can dissect exactly around the tumor. This is a stalk displaced to the left side, and it can be nicely dissected around the tumor. This is not a tumor capsule. This is a paper-thin hypothalamus. But with a high resolution of an HD camera, we can dissect it. And then the last adhesions to the floor are cut with scissors. And then the tumor can be taken. And you see there's almost no manipulation of the optic chiasm because the tumor is right under it. We have a small third ventriculostomy, so it's a small hole in the floor of the third ventricle. You see, when you look inside, you see the mesointermedia media, but all the vessels are preserved. So that is a very atraumatic way to deal with it. And you see after 14 days, visual field improved, visual acuity recovered. And you see he is now 11 years after surgery, and although we preserved the stalk, no recurrence. Fred always said he cannot believe when we preserve the stalk that we can have a gross total resection with no recurrence, and he always showed some examples. But I think in some patients it's possible. And you see no gain of weight. He needs a little bit replacement of thyroxine and also of testosterone, and a little bit of hydrocortisone. Otherwise, he's doing very well. The Trans-Infantible Craniophangeoma is more difficult because the tumor is within the stalk. You see here, this all are fibers of the stalk displaced. So what we usually do is we open on one side and we evacuate the content. Most of the tumors in our series were cystic, partially cystic. And then the question is, should we resect this? But if you look here, you will resect whole floor of the third ventricle, you will destroy the stalk, and in many cases you will have endocrinological problems. So one example was a 29-year-old female. He had problems, and the girlfriend sent him to the doctor because she was not happy with his performance, and they found a pituitary insufficiency. And you see there's a large midline tumor, very inhomogeneous, but if you look from the lateral side, you see it's really filling the whole third ventricle. Many people say transcallosal would be the best to approach his tumor, but if you see, this is a longitudinal axis, this again is a chiasm, and this is a gland. So in this case, we have almost 1 centimeter space, and that's why we thought it is an ideal approach to come from the nose. You are already open, pituitary gland, optic nerve left, right, you see the arachnoid. So we open the arachnoid. We always make a bony opening wide to have enough space for manipulations. Then we incise the tumor capsule. We should preserve as much of these branches because they supply the chiasm. So we make a debulking of the tumor. Then we try to find the right place. So this is not a tumor capsule. This is all the infundibulums, all stalk around. Ultrasonic aspiration is sometimes very helpful. And here we have to find the right plane to go around. So this is all the infundibulum. And you see the tumor is not coming down. So I have to use a 45-degree endoscope, and then I have bimanual dissection. And as long as you see this gliotic plane, I think it's safe to dissect the tumor, but you should not pull on it, but you have to dissect. You have to go really around the tumor, dissect it away from the third ventricle wall. It's ill-advised that you simply pull on it. And you see, I have to bend my suction because the tumor goes so far up, I could not reach it with my forceps. And that's why with a microscope, it's impossible to get it because this is a 45-degree endoscope. And only if the tumor is dissected, then it can be removed or should be removed. And then we look in, you see this is the roof of the third ventricle, this is the aqueduct, and here are the foramina of Monroy, seen from below. MRI shows gross total resection. He's now 8 years out of surgery. So far, no recurrence. And he needs full substitution. Even we preserved the stalk. He has DI. He tried to leave minorine away, but it was not working well. He had to drink 8 liters a day. But the good thing is he did not gain weight. What we do with tumors of this size is an old lady. She has endocrinological completely intact, has only visual problems. So we went in, we see the cyst, we decompress the cyst, But if you look at the stalk, it's infiltrated. Should I resect it? We decided not to do it. We just decompress, and then we sent her for fractionated stereotactic radiotherapy. 30 fractions, and you see no recurrence, and so far she does not need any substitution. Similar advantage, this is an 84-year-old female, visual deficit. So what we have to do, we decompress the optic chiasm, dissect it, but here you see the stalk again is infiltrated. Because she was initially okay, we decided to leave it. This is a remnant of our surgery, and then we added fractionated radiotherapy, and you see the tumor is melting away. It's hard to see, and she's doing fine. She does not have any DI, and she has improvement of visual field. So I think if there is good function, we should also consider that radiation, and partial resection is a good option. And you see, even after 20 years, we have a high rate of tumor control. So the last type is a retroinfundibular tumor. The first thing what you see is a stalk, and the tumor is behind. It's a little bit more difficult to dissect, but with an endoscope, it's also possible. So we go in here, we see the stalk, and then on the right side of the stalk, there is a tumor. So we dissect. I like to have bimanual dissection, traction, counter traction if possible. Also, we have to use a lot of sharp dissection. You see, this vessel is a superior hypophyseal artery supplying the chiasm. It's not a tumor vessel, should be preserved at all means. So we dissect it around. Then you see here, there's a tumor adherent to the floor of a third ventricle. So again, with bimanual dissection, solid part is removed. And then the last part is also dissected in bimanual technique on sharp dissection. And the tumor can be removed. And you also improve very markedly. He also did not gain weight. That is, I think it's a better rate than with the transcranial approaches in my experience. And he needs some replacement, but he has no DI and no gain of weight. So we compared our series of tumors, which we did transcranial surgery with the recent endoscopic endonasal surgery, and we had a higher rate of stalk preservation, and we had also a better rate of DI. So my philosophy in these suprasellar craniophangiomas is, if the patient presents with pituitary insufficiency and DI, of course we can sacrifice the stalk. If the patient is endocrinologically intact and the tumor can be dissected with preservation of the stalk, like in the pre-infundibular types, we aim for gross total resection. But if the tumor resection would result in destruction of the stalk, like in the intra-infundibular type, then I think, especially in the older patients, we can leave a remnant and make radiotherapy because we preserve the function. And I think DI for an old patient is not a good result of the surgery. So I think for craniophangiomas, the endoscopic endonasal approach in most cases is really the best approach. We don't talk about these huge tumors with lateral extensions, that's clear. But for the midline tumors, I think it's the best technique. Thank you for your attention.
Thank you, Henry, for this beautiful presentation. There is any comments, question? Rudolf, I push you.
Danny?
Yeah. Franco, Tomasello, please.
I would like, Henry, my congratulations. It's an excellent presentation. And I agree completely with you that most craniopharyngiomas can be resected by an endoscopic endonasal approach. But I would like to ask you, what approach you use when you are convinced that the craniopharyngioma is completely inside the third ventricle?
It depends. So we had patients, they presented with the Edison crisis. So then I know the stalk is already destroyed. Then you can come from the nose. And I had one case in this. If there is a good function, then I would prefer a translamina terminalis approach if it's a small tumor in the midline, or the transcallosal approach, depending for it. So if the function is gone, then I think we can come endonasally. But if the function is good or there's no problems, then I think it's better to come from a transcranial approach.
Okay, thank you.
Okay. Any other comment? Yes, Imad?
Yeah, what about heavily calcified multi-chamber craniopharyngioma? Are you still going from below to decompress, or we go from above from the start?
Yeah, I had a patient with a calcified tumor, and it was really a mess, but we made an endonasal approach. But it took a long time because, you know, the cruiser is not working, and you have to sharply, with there's a 2 centimeter forceps from the ENT where you can go up, very much up, and you can bite it. But it was a long piecemeal resection of the tumor. Took a long time. When I see there is a lot of really big calcification, like in a child, but we had recently, we made a pterioid approach, a pterional approach to get the tumor transcranially. But this was really heavy, even with a ronger, it could not cut this bone. It was so calcified, it was really amazing.
I have a lot of sympathy with that. We had a pediatric case with very narrow window between the carotids. And again, stone hard, and took absolute ages, and just couldn't cut the stone eventually with anything.
Yeah, you should try TNT. Maybe this is working better.
If there are any other comment, I have a small question. In your philosophy slide, you did not mention the age of the patient. Do you think that is quite different if you have the pediatric or, let's say, young patient and the oldest one?
Yes, sure. There's no question.
The presentation, there was a lot of difference between the two, but I would like to make if you can make a statement on that.
Yes, of course, it is different, especially regarding radiotherapy. If you have a very young child, of course, you cannot radiate. And sometimes you make a surgery where you decompress the optic chiasm and then just see that the patient comes maybe to puberty, and then you make a definite treatment. In my series is made mostly adult patients. We had only a few children, and then of course it's different. So the recommendations that we make this partial resection, if the stalk is invaded, is mainly for adult patients. But also in pediatric patients, there is a big study in Germany underway from Dr. Hermann, and he is collecting all the cases, and he is not a surgeon. So when he analyzed the results, they are not the same optimistic regarding surgical outcome than from the surgeon itself, because he sees a lot of patients who got obesity, had mental problems. And that's why this is a proponent to make a less aggressive surgery, even in children, and make radiotherapy, because he shows always a slide where the recurrence rate is the same with gross total resection or subtotal resection and radiation. Because, you know, in many patients, when you have a gross total resection, you still get recurrence.
Professor Falbusch has a comment, I think.
Sure, he should have.
I have a principal question to the stalk. So you said always infiltration of the stalk. Shouldn't we say the stalk is the origin of the tumor? So it's not infiltrated, it originates from the stalk. And another observation I made, sometimes I never have seen the stalk, although the patient has excellent functions after, because it's so far laterally displaced that you cannot see it. And then I propagate partially resection of the infiltrated, now it's the right term, infiltrated area, maybe 1/3. And then the pituitary stalk works. It's not only the question of your resection or what you have done, it's also the question how you manipulate the stalk. If you really turn it around and manipulate it, then maybe he will not recover, although it has a high potential of recovery.
Yeah, sure. Each case is different. For example, in the case what I showed, the first one, there was a good plane. So I had not the impression that really the stalk is the origin. Maybe it's a little bit higher up.
That's interesting. That's interesting. Yeah.
Yes.
I agree.
Patient, you know, sometimes the craniophangiomas are only in a third ventricle, and then you have a good chance. But if it's directly coming from the stalk, in this case, what I have seen, I could not split it to 1/3 taken and 2/3 leave because it was so thin, like paper going around. Especially in the intra-infundibular or trans-infundibular types, it's very difficult, I think, to preserve it. In the guy I showed you with a huge tumor, there was a good plane to dissect it, but this manipulation with stretching and dissecting this this is probably the course that's not working well.
Okay, thank you, Henry. And we stay again in the craniopharyngioma. It's a pleasure to introduce my friend Rudolf Farbusch, the same subject, but we heard his personal experience. Rudolf.
Is this here? PowerPoint. This here?
We see you. You have to share the screen.
Yeah, I've done it.
Good.
Ich muss da hingehen, warte mal, den hier legen. Der macht's aber nicht. Das weg. Danke. Okay. First, congratulations to excellent pictures I've seen by Henry. Very, very impressive. So when I was the Botterell lecturer in Toronto about 20 years ago, my friend Frank Gentili was my local host. However, he was in a critical situation because he has lost his wife and also lost his confidence in microsurgical manipulation of the pituitary area, especially missing adequate endocrine results. That is why he switched over to the endoscopic technique. Macht er nicht.
You can use your mouse.
Yeah, doesn't work here.
Yeah. Click the left button.
No, it doesn't work. No?
Yes.
Does it work? Yes. Okay. And again, I'm impressed by this wonderful endoscopic pictures, the tumor before and after total removal from Fred. And if you look to this tumor before and after surgery, it is similar to what you see here. My tumor, a little bigger, more retrocellular, a little more above after total preservation. This is the goal. Selective removal with preservation of function, and especially hypothalamic sparing is the focus today, especially by endocrinologists. We should not touch the hypothalamus. However, it's not only the anatomical structure, you see here the nuclei, it's mainly the function, the endocrine function well defined, the vegetative function, as you see here, not available by adequate functional tests today, and that is a dilemma. If we could predict before how far this works, we could even act in the hypothalamic sparing procedure much better. And all this depends on experience, selection, and approaches. I overlook nearly 400 cases, starting in Munich and now in Hanover. And during my Erlangen time, I published this number of cases. Finally, increased safe radical resection is what I like to do. The many preferred approaches, and you need them all, is sphenoidal, nearly as many as frontolateral. Transsphenoidal, in my management, if it is infradiaphragma, and supradiaphragma, but subarachnoidal. Classical case, transsphenoidal, when the pituitary gland is in 50% anterior located, we have to split the gland to remove the capsule totally. This is the typical type, before, mainly cystic, after operation with preservation of the stalk. And if you CSF, we put some fat tissue on the floor to manage it. This is the overview after removal of the cellar floor. We split the gland, we enter the gland, we prepare the capsule, remove it, and see the descended diaphragm. Short video shows how we dissect the gland. Remove the tumor, with a small curette. And then open the dura a little far to lateral to prepare the capsule from the diaphragm, which comes here, from the wall of the cavernous sinus on both sides. And finally, to remove it totally, the water you see is not CSF, that is only irrigation. The extended supradiaphragmatic procedure can be done in the smaller lesions easily if you split only here the dura. But I come to the transtubercular approach in my series Subarachnoid. And when you have removed the tumor here, and especially the capsule, you have a wonderful look, as we have seen beautifully by Henry, to the pituitary stalk, to the chiasm, and as always, the arachnoid should be preserved. If we talk about transcranial approaches, nearly 46%, there was always a hypothalamic, nearly always hypothalamic connection. When the hypothalamus was displaced, fortunately, we have a double hypothalamus. One works nearly always. And the floor of the third ventricle is attached or invaded, perforated. The tumor can be mainly also in the third ventricle. We have to take care about the stalk. We discussed this about vascular supply. Here we prepare the capsule in another way. It's more a gliotic layer as soon as the tumor has reached the connection of the brain. And we should respect the arachnoid cisterns. Even in the large tumors, the giant tumors, we're at 16 among 68 in our series in INI, which are published together with Majid. We could remove them totally in 40 of 16 cases. That is nearly 90%. I'll give you some examples. Pre and post-operative, a tumor which was supra and intracellular located with preservation of the pituitary gland. You have to take care about these perforators coming here directly from the carotid artery and here on the contralateral side from the posterior cerebral artery. A short video. After suctioning CSF, we come close here to resect the tumor in an arachnoidal layer. Here also. Lateral from the carotid artery. Also here, and we have the pituitary stalk here preserved. It is also helpful in the antefixed tumors to perform a clinectomy, anterior clinectomy, to move the pituitary stalk more easily. And I think a domain of transcranial is also the lateralized tumor, as you can see here, before and after resection. Here you see the stalk, how far it was displaced to lateral, and the optic chiasm. Here the tumor has undergrown the carotid artery to lateral, and you see after stepwise removal, also via the lamina terminalis, you see here the optic nerve. Coming to a larger tumor with retrocellular extension, also completely removed here with preservation of stalk and pituitary gland. And you see the small anterior part sticking at the, or originating better, from the stalk. Here I made a 1/3 dissection of the tumor, and this is the lamina terminalis approach. Also a short impression with a video on that. Well, to start here with the opening of the lamina terminalis. enucleating of the tumor. We see the trunctus, and a little more up to suprasellar, we see the dissection within the glenotic layer. Coming to comparison, the expanded endonasal approach, mainly from the Pittsburgh group, you see that in the beginning, they could remove only 50% at a very high rate of CSF leaks, then improved over the years. This is the last publication, 47%, maybe in comparison to 2012, a little higher, but still a high amount of CSF leak, which we don't have in transcranial surgery, of course. And this is Fred's publication. He had 44% gross tumor removals, but he has a number of pre-treated tumors. And if you take only the untreated, he has even the same rate, 77% gross tumor removal, but still a high rate of CSF leaks when 5 were only reoperations and still high recurrence rate. Superior approaches, transventricular approaches in such a tumor, which reach nearly the corpus callosum, and we were nearly down to the cellar, as you can see here, possible. However, there are limitations, intraoperative limitations. Besides calcification and firmness, we can have hypothalamic structures which are attached and perforating arteries also, which can contain tumor parts. And in this case, we had repeated bradycardia always when I touched this tumor part and had to stop surgery. Fornices and memory can be reached by the tumor. Here's suprasellar, green. That is functional navigation. And here with the intraoperative MRI, you see total tumor removal and also preservation of the fornices. Contraindication for direct surgery, functional limitations. Here is a peritumoral edema and obstructive hydrocephalus. When this was shunted and under dexamethasone, a reversible edema, we performed surgery and removed the tumor totally. However, the preoperative obesity deteriorated. Radiotherapy, primary procedure in this tumor, who had irreversible severe hypothalamic dysregulation, as you can see here, especially alteration of sleep and wake rhythm. Irradiated with an excellent result, but this is not always the case. You see here 10 years after radiotherapy, no hypothalamic dysregulation, no visual deficits, however, hypopituitarism. Complications, very few in transphenolial surgery, a little more in transcranial surgery, among them 2 patients with severe hypothalamic dysregulation, one of them died. Does cranial size limit complete resection? This is the gross total resection percentage, and these are the size of the tumor. And the smallest tumors in my first series, that is yellow, was always nearly 90%. However, I improved over the years. I started with 30%, but meanwhile, I'm nearly 90% with resection, even in the large tumors. Additional new hormonal deficits, very few following transnasal operation. However, diabetes insipidus, 25%, more in transcranial operations, especially in the last a little more aggressive operations, 10 to 20%. Improved vision between 86, 78%, nearly the same sphenoidal, transnasal, and transcranial. Does the transcranial approach affect neuropsychological function? There was no worsening, more improvements in these tumors. Does it maybe induce obesity more in giant craniopharyngioma in children? 9 of 10 with a pre-existing obesity, in 6 no changes, in 3 transitory deterioration. Coming to the end, this obesity risk was mentioned always by a wonderful paper by Martini, who was on the transcranial side more, but he compared transphenol and transcranial. He said on one hand, surgical approach does not influence obesity, and then depends more on preoperative hypothalamic functions. And in agreement with Paolo, who is present, this scenario, endoscopic endonasal technique, proved to be a valid approach. And finally, I started with Fred, and I end with Fred, with his postulations. And I totally agree, his inclusion, but also his exclusion criteria. We are more a domain for transcranial surgery, consistent results for vision and endocrinologic outcome with published transcranial and endoscopic series. Thank you very much, my dear friend Gentili. You made a great distribution in neurosurgery, and we will not forget your results, your work in neurosurgery, but also you as a human being. Thank you.
Thank you, Randolph. Wonderful presentation and question a little bit complete on the cranial approach.
I cannot hear anything.
Endoscopic one. There is any question or comments?
I cannot hear you.
Henry?
Udo, can you hear me?
Yes.
Where is he?
He is frozen.
No, it's closed.
Like internet connection.
Any other comments or question?
Yeah, I want to ask him about the difference in approach for kids and adults, whether he sees the difference in radicality and so on.
I think it's gone. It's probably good. ICE here now.
It's muted now. I think it's working, but it's muted.
Working, but it's muted.
Yeah, now.
You must unmute.
Yeah, important question. On one hand, of course, you can do a little more in children than in adults because they recover much more easy. On the other hand, they have a long life in advance, in contrast to a 75 years old patient, which both of us have shown such cases. And I think especially the pituitary stalk is an important thing. And I always would try to preserve it, even if I would leave a tiny part and hoping it will not grow. We didn't discuss this. There are many patients who have a tumor remnant which does not grow. That is why in children, I would not always perform in the smaller remnants radiotherapy. I would wait and see. So that's the difference.
Okay.
Any other comments? Yes, Thomas?
Given the sort of proximity to the fornices, have you seen, Professor Falbush, relatively worse memory outcomes through the lamina terminalis approach, or not really?
No, the main problems we had when we went transventricular, intracallosal, for example, then it can happen that you have, as minimum, transitory short memory deficits. And I've seen, I think maybe one patient who had it very long, and I don't know, I haven't seen him again, maybe forever. That can happen. Although some people say you can sacrifice one fornix and the other would work. So I never tried that.
Thank you.
Any other comments? One question to all the experts in craniopharyngioma. There is no space for mainly for very elderly patients that have major cystic tumors to this marsupialization through transventricular or to injection of interferon or so.
So we have experience with purely intraventricular cystic ones in older patients. What we do is we make a large resection of the cyst wall, but we leave the infiltrated, usually calcified floor. And then we did what Rudo also said, we observe, we make follow-up MRI. And if we see it's growing, we went for radiation. Because these tumors, I think if you make a gross total resection, the stalk will go away. And in the older patients, I think it's no need to do that. And really, we had never seen a recurrence after the radiotherapy, what we do in our department.
I completely agree. I guess that the elderly patient craniopharyngioma maybe is biological a little bit different of the younger.
Yeah, sure.
If they have some morbidity, I could offer also the cystoventricular shunt. So the larger cyst can be shunted into the ventricle, and that would help also. That is also one of the options for recurrent tumors, which recur again and again. So in the elderly more than in the younger.
But in these cases, I have seen patients with outside treatment from our institution. Frequently, this catheter get blocked sooner or later.
Possible.
Thank you. Pass the chairmanship.
Giovanni.
Oh, Iman.
Giovanni, I have a question.
Yes, so please.
For Professor Falbush and my dear friend Henry, do you see transformation into malignancy post-radiation? We did have seen one recently that received radiation on a residual remnant craniopharyngioma, received radiosurgery actually several years ago, and transformed into malignant craniopharyngioma. When I reviewed the literature, there are sporadic cases talking about it. Have you seen this one in your practice? And this what it brings me to the idea of Professor Falbush. Once he leaves a residual, he won't jump immediately into radiation therapy. I don't know, perhaps we should wait a little bit and see if there is any signs of progression or not. What is your take on this?
I agree with the observation. And the other thing is the malignant craniopharyngioma. I've seen one patient, 14 or 13 years old girl from Iran together with Majid. We've done, I think, within 2 months, 4 or 6 operations in her. She didn't survive. It was a primary malignancy. I've never seen this before and never seen after. So not automatically radiotherapy would induce that. It can be also spontaneously, but very rarely.
I have never seen it in none of our cases, but we make fractionated stereotactic radiotherapy, 30 fractions. And then the radiotherapists say that it's better for the tissue to recover. It's better than a single shot, especially in craniopharyngiomas where it's close to the optic chiasm. They also recommend fractionated.
Radiosurgery is rarely indicated in smaller tumors, I think, not adjacent, not attached severely to the optic chiasm.
Yes.
But there are people who do it with protons, and they are also with a, what is this robotic, the cyberknife also something. Okay, Kaspar.
Just want to comment the question about when to deliver radiation was well answered in the literature. It should be given at progression of disease, not immediately post-op to treat residual disease, because some of them basically freeze and don't change. And as you delay your radiation for progression, you delay morbidity. Hence, you have a favorable outcome if you delay your radiation treatment. The last thing I want to say is there's an outstanding series of intracystic craniopharyngioma treatment with P32 by our Chinese group in Beijing. Professor Xin Yu has really the largest series in the world and has just published an outstanding paper on local control rates, which are outstanding for purely cystic craniopharyngiomas, purely treated with stereotactic radiation. I know that the technology is difficult to handle because of the dosimetry with colloids, but at the same time, it's minimal invasive, it's minimal morbidity, and the local control rates are as good as any others. So look this up in the Red Journal from International Journal of Radiation Oncology and Biophysics.
Thank you. So I thank you for question of time. I pass the moderation to Pablo, and I thank you all the experts that give us this beautiful lecture.
Thank you, Giovanni. So we keep going with the next talk. Sanjeeva Jayaredna, he's going to talk about skull-base endoscopy operating in the coronal plane. Sanjeeva.
Thank you very much, Pablo. I'll just share my screen. Just start my timer so I know what. Thank you very much for this opportunity. It's a real pleasure to be here from our former collaborations with WFNS and now in our new International Academy of Neurosurgical Anatomy. And it's a real honor to be talking in honor of Fred Gentili. Of course, has been a huge inspiration to a lot of us here in the United Kingdom. Tom spoke very nicely about that earlier, not just in open surgery, but of course, a lot of the contributions he did in endoscopic surgery. So I've got 15 minutes to go through endoscopy in the coronal plane, so there's a lot to cover here. But I'll try to highlight some important points that I think are important, particularly for people who may be just starting out with doing endoscopy in the coronal plane or skull-base surgery in the coronal plane. I spoke about this before in one of our earlier sessions, but I think a major importance always is looking at the tumor biology, and there are, I think, some cases that are clearly just not appropriate for endoscopic work, and some that hugely lend themselves to endoscopic work. And I think as a skull-base surgeon, you have to see the two as being hugely complementary. And of course, the picture on the left is just a nice rotund dissection, and I've talked about this before, about how we plan the open approaches, and depending on the anatomy of the posterior fossa, how you decide whether you're going Kawase, transpetros, bilateral, or just retrosig. And similarly, we have to have a similar understanding of this picture here of the clivus. Of course, that's more in terms of sagittal plane operating, but understanding that anatomy and then looking at your tumor biology is very important. So I know a lot of people would favor, in this bottom left picture here, going endoscopically for some tough meningiomas, but I don't. I hugely favor the soft tumors where the dissection is more straightforward, like this chordoma here, or even on the far right here, this petrous apex granuloma. So when I'm thinking about endoscopic surgery, I favor that. Sometimes you don't have a choice. I'll show one case just because of the anatomy of the cavernous sinus and the carotid that actually we had to go endoscopically for a sort of rock solid chondrosarcoma. But as a general rule, for much tougher tumors, or I think there's a large risk of the CSF leak, something I'd favor an open approach. Having said that, the endoscopic approach is hugely important as a skull-based surgeon. So when we're talking about the coronal plane, I think first we have to understand what the definition is. And actually, I quite like this picture. I think of the definition slightly differently, but this was 15 years ago when Danny Pravdello, Kassam, Carl Snyderman, Paul Gardner were all in a paper together at the time saying, is endoscopic surgery ready for prime time? And I think we all fully agree it clearly has. But they came up with a fairly good schematic, I think, for discussing the coronal plane. And I think about this very similarly. But essentially for me, if you imagine this anatomy, you've got the pterygoids here, sellar floor, and the carotid artery. And for me, the key is the carotid artery. We're all used to being in this area here, and I'll show a picture of that. But when you start to move laterally, whether it's all the way out to infratemporal fossa, if it's just pterygopalatine fossa or petrous apex, that's what I think about when I think about operating in the coronal plane. So it's moving lateral to the internal carotid artery. And I'll show examples how, we've got as far out as almost where the carotid canal enters into the skull base. But this is what we're talking about. We're now moving away from this midline, which we're very familiar with, and we're going to move out laterally. And there's various definitions. This is one example, as I said here. And I suppose the two major ways to think about dividing is either you're going to divide based on pathology, and that's what I was talking about a little bit earlier. So, a whole range of pathologies here, solid tumors in the orbit, softer tumors. We talked about the granuloma, rock solid. This is the rock solid chondrosarcoma I was talking about that really pushed the carotid laterally. Or maybe what's easier in keeping with the goal of our society to really discuss anatomy is to divide anatomically. And so if you're going to divide anatomically, you first have to talk about the basics, and that was covered nicely in one of the earlier talks. So this is the basic anatomy that we really understand well. It's a nice Japanese paper here. And before you start anything, before you start to move out laterally, you have to understand this basic anatomy. So cadaveric dissection, you're coming in endoscopically, you have to understand where the sella is. You have to understand carotids on either side, the optic nerve prominences, and then your medial and lateral optical carotid recess. And that's just a very, very basic anatomy first. And a lot of people will then start, moving to tuberculum or planum as labeled here, but we're going to talk about moving out laterally. So that's that picture here. So once you understand that basic anatomy, you're now going to start moving out and laterally. And of course, if you understand this and you're used to seeing, the optic nerves, then actually one obvious place to start next is going along the optic nerves and into the orbit. That's not something that I do routinely, but a lot of my colleagues do, and that's the first place we're going to go to in terms of the resections. But I think one of the big secrets, and there are two important things to really understand when you operate in coronal plane. One for me is really middle turbinate and moving lateral and opening lateral to the middle turbinate. Second is the carotid artery. So I want to talk a bit about the middle turbinate, and I think this is the big key. And this is a sort of slightly long video that I'll just play while I'm talking. But here we've come in and you've got the middle turbinate here, and this entire video, we're dissecting part of it, but we're preserving the medial side of the middle turbinate, and we're going to work lateral to the middle turbinate. And almost every operation we do in the coronal plane involves this maneuver, where we start to open the anterior and posterior ethmoids, open the maxillary sinus, we're opening the uncinate and the bulla, and we do this routinely in almost every operation that we would do where we're working in the coronal plane. And this is important for us for two reasons. So just to be clear, we're different to what some people do, where they resect the middle turbinates. We never resect the middle turbinates. We think they're really important for olfaction in cases where you're trying to preserve olfaction. And also we think, they're useful generally in terms of protecting the mucosa, particularly the mucosa of the middle turbinate, and reducing some of the morbidity associated with it. As you know, crusting, as neurosurgeons, we don't get too worried about it, but my ENT colleagues do. And of course, for patients, it's a big deal. Crusting is a big issue. So understanding middle turbinate anatomy, understanding the horizontal and vertical attachments of the middle turbinate, the blood supply coming out of pterygopalatine fossa, but importantly, its relationships to the maxillary sinus laterally, and then the anterior and posterior ethmoids and how you open into it. So I'll skip forward in the video just so you can see using a microdebrider here. But this is a big thing that we don't talk about a lot. We've really medialized the middle turbinate. We're working laterally to it. We're going to open the uncinate and the bulla, some of the bulla there, and we're going to go into the anterior and posterior ethmoids. So I'll skip forward some more. And you can see we get a huge amount of space that then allows all of the other things that I'm going to talk about. I'll just, in the interest of time, I will skip, we got uncinate coming out. So you can see maxillary sinus, back wall of maxillary sinus, pterygopalatine fossa is going to be back there. You're going from the smaller anterior to the larger posterior ethmoid cells, and that'll allow you to get back into the cellar. Okay, so and you can already see we've got this large sort of working channel. I'll move forward, but this is key. This middle turbinate anatomy working lateral to it is really important in the coronal plane. Okay, and then the next really big and important thing to understand is the carotid. And of course, we understand the paracellar carotid well, and that's paraclinoid and cavernous carotid. And we know that from pituitary operations and working out laterally in the cavernous sinus in pituitary surgery. But if you're really going to work in the coronal plane, the next key bit to understand, of course, is the lacerum and paraclival here. So that's what the yellow lines mark out. You've got paraclival carotid, cavernous carotid, and then paraclinoid. And we have a huge experience in understanding these carotids from what we do in open surgery. And it's very important to be able to translate between the two. And the important landmark here, of course, is the Vidian nerve in the floor, Vidian nerve, and then as you move out laterally, rotundum. But the Vidian canal is hugely important in terms of marking out the lacerum segment. And we understand that from our anatomical dissections. And I think of it, and I've spoken about this before, I think of it a bit like the petrolingual ligaments. So when you're coming laterally, this is now a lateral view. And when you have to understand this view to really understand what you're doing when you come endoscopically here. And the key bit of anatomy to understand here, you see Vidian nerve coming to your lacerum segment, and the petrolingual ligament, and of course the sixth nerve just above that. And when you're working from the front, you must have all of those pictures in your head, so you're able to picture the carotid. Of course, the carotid isn't going to be in this normal segment here. And for most of the tumors in this area, it's very easy to injure the carotid unless you've got a clear understanding of the normal anatomy, because it's going to be very distorted by the tumor. The other important thing to understand for people who are just starting out is, of course, the very anterior segment here. When you're working now, moving away from the safety of the pituitary gland, you're moving out laterally, is that the anterior genu in the cavernous segment protrudes forward, particularly when you're removing bone and things. It's easy to injure at that point there. After that, it's, as I say, using a Doppler is key, because unlike when you're working open, you sometimes don't get a clear view of the anatomy. Obviously, you get bleeding and things when you're in the cavernous sinus. and using Doppler and the same sort of dissection techniques used in the pituitary are very, very helpful in working in this area. But understanding this sort of anatomy of the carotid coming forward, ascending in the paraclival segment, it's cavernous, and paraclinal anatomy is very important. I don't use a lot of image guidance when I go open, but I do find it very useful in endoscopic surgery because I feel sometimes the anatomy is less clear for us as neurosurgeons, and I find that quite helpful. So we've covered a lot of this in our previous talks when we looked at the cavernous sinus and things like that, but essentially the important points here are really understanding how the carotid turns, you having your landmarks like the Vidian nerve for picking up the lacerum segment. And so when you're first starting out, I think orbital apex is not a bad place to start. And of course, the important thing here is you usually want to work on tumors that are medial or inferior to the optic nerve. Anything on the lateral side, we would then we would want to come open or lateral. I've just put an example here of most of the tumors that I operate on. I tend not to do the smaller tumors or even thyroid eye disease where we're decompressing medially, which my ENT and ophthalmology colleagues do. A lot of what I do involves coming open, but occasionally we will team up, particularly this intracranial extension. But usually we're looking for tumors that are medial or inferior if we're coming endoscopically, but a good place to start if you're starting to move out laterally. And of course, the next place that we're all very used to working in is the cavernous sinus. I put this tumor here as a good example. Obviously, it's on the lateral wall, not within the cavernous sinus. It's a meningioma. That's something you definitely wouldn't go to endoscopically. But actually, all of the others are options, including this, which I wouldn't normally favor, but this is a rock solid chondrosarcoma that we did endoscopically, invading into the cavernous sinus. Because the carotid and the cranial nerves are all displaced laterally. So actually really lent itself very well for an endoscopic resection. But this is the next place to come. And again, as we discussed in the previous slide, in the interest of time, I'll keep moving forward. But again, it's about understanding the anatomy of the carotid and really, you know, if carotid and cranial nerves are displaced laterally, particularly in soft tumors, and this is a very good next step in terms of moving out laterally in working in the coronal plane. Of course, this is a nice anatomical dissection showing some of the fantastic views you get. This is particularly important in chondrosarcomas and things. You have the sixth nerve here coming into Dorello's canal along the carotid. The other important bit of anatomy to understand that, of course, is not in this picture, is the inferior petrosal sinus. And you can get a lot of bleeding when you're coming endoscopically, but just like the cavernous sinus with flow seal or Surgiflow, whatever, very easy to control. And a nice sort of next step, as I said, is the cavernous sinus. So this is an area where I hugely favor operating endoscopically. I think it's a nice one where you can mix. I'm showing examples again of soft chondrosarcomas and things where we would definitely. Oh, sorry, these two are the granuloma, soft chondrosarcomas. This one actually became open because of the position of the carotid. In splitting the cavernous sinus laterally, but certainly for ones where carotid is displaced laterally, we hugely favor endoscopic approaches for it, and it's another good place to come. But again, really important to understand the relationship of the tumor to the carotid, and I've shown this picture before. But when you look at these sort of scans, what you really have to understand is this picture here, and you can see the carotid in its cavernous segments and paraclival paraclival segments, and you can see how the tumors wrap around it, and being able to understand that is important. I don't think it's unreasonable when you're starting out to mix endoscopic for the medial bit and open or pure open, or whichever you want to do. I think that's all very reasonable things to do. I put the 7th and 8th cranial nerves here because actually you have to understand that some things are just too lateral, and reaching out to 7th and 8th nerves endoscopically is very hard. I know there are very good surgeons like Sebastian Freulich who have nice angle instruments and can get out there, but actually you have to understand some of the limits in the angle of your instruments and how you're limited anteriorly by the position of the carotid. You will not be able to reach out laterally. You just don't have the angle sometimes unless you've got very good angle instruments. Again, that's where soft tumors are favored, whereas rock solid tumors like the one I showed earlier is very, very difficult coming out laterally.
One more minute, Sanjeeva, sorry.
Sorry, how much longer have I got?
1 minute.
Okay. And then finally, tracheopalatine fossa and infratemporal fossa are nice places to go when you're out on the coronal plane. And again, it's about understanding that middle turbinate anatomy and moving out laterally in the anatomy of the tracheopalatine fossa. You've seen this before, so I'll just skip forward. But the key point here is, again, we've kept the turbinate anatomy intact. This is becoming for a tumor of the back wall of the maxilla and the tracheopalatine fossa. But I'll just skip to the end just to see that you get this beautiful anatomy of the pterygoids and vessels within the tracheopalatine fossa, which is very nicely seen. Really, really, really good for endoscopic surgery. There we go. Lateral pterygoids, infraorbital nerve, all of that is really seen. As you go out through the pterygomaxillary fissure, you get into infratemporal fossa very easily. And that's the next extension there. Again, for very large tumors, I'd favor mandibular swing coming laterally, but for tumors extending outwards, smaller tumors, it's very reasonable. Just to show, you can get almost all the way out lateral there with a malleable sucker and a soft tumor. This is just to show we're almost where the carotid is entering the skull base, coming endoscopically with the malleable sucker. So you can get quite a way out lateral on the carotid. Anyway, to summarize, the key bit of anatomy maybe people don't talk about a lot is moving out lateral to middle turbinate, keeping the middle turbinate. It's good for preventing crusting, keeping olfaction, really understand carotid anatomy. Some of the key landmarks of the median nerve, use the Doppler. A lot of these extradural tumors, so CSF leaks are not a big issue, and you can combine it with open approaches. Thank you very much.
Thank you, Sanjeeva. I'm sorry I had to interrupt in the most.
Don't worry, I think I'm 12 seconds late, so I apologize.
Thank you so much.
Thank you.
Any question from the audience or the panel?
Hi.
I have a question.
Henry.
Yes, Sanjay, great presentation as usual.
No,
but I don't agree what you are saying about olfaction and the middle turbinate.
Oh dear.
There are a lot of examinations showing that the superior turbinate and the medial septum, the upper part of the septum, are important. And there are some olfactory fibers sometimes over the middle turbinate. So it depends how far you cut it. Usually you don't take everything up to the skull base, but you leave a little bit just to get space. And I agree with you, if it's possible to preserve, we always try to preserve. But sometimes it's very narrow, the condition, and then it's better you take it because it's very difficult to harvest the nasoseptal flap and so on. So I don't agree that you say when I take a part of the middle turbinate that I disturb the olfaction.
I think you're probably right about the olfaction part, but sorry, Henry, I'm going to disagree on a small point. I think you can get a lot of space by, you can take the lateral part of the middle turbinate, you open the bulla, you take the unsnared, you take antripos ethmoids. I'm not sure taking that bit of turbinate adds a lot more space. I don't know, maybe as you're coming forward, maybe you're right. But as you're going backwards and lateral, do you think so? Do you think it gives you that much more having to take that middle turbinate?
No, it depends. I think it depends from the individual anatomy. Usually we try to preserve, as you do. And if we have the concha bullosa, we do the same. We cut half of it and displace it laterally. But I don't agree that the olfaction is disturbed. That was my point.
No. I think I agree. You're right. The superior all play a role.
Thank you.
Thank you, sir.
Ramesh?
Yeah, I was going to say the same thing about the middle turbinate. I operate with the ENT surgeons all the time. Even though you're worried about the nasal quality, I think it's often, if you can preserve it, but they wouldn't worry too much about taking it out if you're struggling with the space. And also leave a stump of the middle turbinate at the roof, which is actually a landmark for most of the ENT surgeons. And I think, if you are struggling for space, I wouldn't mind taking it.
Yeah, we don't struggle. I mean, we keep it. Firstly, Ramesh, your house looks amazing.
Thank you.
The background, that's very cool. But I have to say, we don't struggle for space. I like nice wide exposures. And once you open the ethmoids, you can really lateralize the middle turbinates out, I find. But yeah, I agree.
Good. So thank you, Sanjeeva. Again, happy to see you.
Nice to see all of you. Thank you.
We keep going, and I cannot see Jose Landeiro. So Is Jose Landeiro among us?
I think Jose is coming with late.
No, Professor Landeiro will be in the second session.
Okay, so let's go for the next one. And we have the honor to have Professor Lucas Rasulic. I don't know where you are, if you are at home or somewhere. Lucas, can you unmute yourself? Lucas, we cannot hear you. Lucas.
So now, can you hear me now?
Now we can.
Okay.
Welcome.
Good afternoon, everybody from Belgrade. In between preparation for the IANS Congress and regular activities such as outpatient clinic, it's my great pleasure to greet you all from Belgrade and to invite you all to come in Belgrade in October for the IANS Congress, which will be a great event. It is my great honor and pleasure to tell you something about surgery of the nerves around craniovertebral joint. I mean, everybody of you already knows that, but it can be interesting maybe for the wider audience for this kind of surgical repair of the nerves around craniovertebral joint. Since this is a pathology which is already mentioned and they have a lot of in common with all other things. As you know, I'm a neurosurgeon doing peripheral nerve surgery. And these are not very frequent lesions, but generally they deserve some attention to be recognized and to see what are the possibilities for surgical repair of the nerves around craniovertebral joint. Congratulations to my dear friends Imad and Vlad who organized this academy and this webinar. I don't have anything to disclose. This is how we met. When I met Fred Gentili in Rome during WFNS interim meeting. This is one wonderful dinner in one of the very popular restaurant in Rome. And my wife and myself, we always remember these nice moments when we have together. We have a lot of memories together. Fred was a great man and a great neurosurgeon. And congratulations once again for organizing this webinar in terms of in memoriam of our dear friend. Anatomy, International Academy for Neuroanatomy is a great institution and society association which remind us always that anatomy is of outstanding importance. So this is anatomy of the craniovertebral joint, atlanto-occipital joint, how it is already also known, and this is what is surrounding all nerves which we are talking today about. Craniovertebral joint anatomy. This is a MRI representation of this, and as you can see, some of the important elements as landmarks are very important to recognize if you want to approach to the each individual nerve around craniovertebral joint. These are surgical approaches to the craniovertebral joint. They are already known, and ventral and dorsal, lateral, to remove the huge lesions which you already mentioned and will be mentioned in the second part, the second session. These are nerves around the craniovertebral joint. So around craniovertebral joint is mandibular nerve, facial nerve, vestibulocochlear nerve, glossopharyngeal nerve, vagal nerve, hypoglossal nerve, cervical spinal nerves, C1, C2, occipital nerves, and sympathetic chain. These are the nerves which are cranial nerves from skull base, but we'll be now concentrate only around for these nerves around the craniovertebral joint. Etiology of nerve lesions can be traumatic, neoplastic, idiopathic, iatrogenic. And majority of these lesions are due to the different types of tumors. And after that, some traumatic incidence is ongoing, and then idiopathic, and some of them are iatrogenic. What we can do for repair these nerves, these are nerve repair procedures. In some situation, nerve decompression; in other situation, direct nerve suture; in other situation, nerve grafting; in other situation, nerve transfer. And it would be ideal if it is possible to have a situation that you can perform microsurgical dissection when you have a large tumors originated from the nerves around craniovertebral joint. So cranial nerve surgery is almost solely done by neurosurgeons. Complex procedures, for example, in facial nerve injuries, including transfers for trigeminal neuralgia, for CP, angioschwannomas, are all done by neurosurgeons only. Let's go through the overview of the nerves, which we are talking now about. So spinal nerves, C1, C2, this is physiological anatomy, which is also very important because we have to know which muscles are innervating in terms of expecting any kind of possible repair. So C1 and C2 are the nerves which are encountered as nerves around craniovertebral junction, and the most common etiology of these nerves are schwannomas. So they are most common, often can be presented with also with myelopathy and with signs and symptoms which are neck pain, worsening of the motor function and sensitive function, and also to let's say endanger within the surgical risk in these circumstances, even vital function. So in surgical strategy, you can remove schwannomas through the usually posterior midline cervical approaches, but some lesions which can be after that can be a question mark for repair, because it is very difficult to find the proximal part of the nerve and distal part of the nerve in these circumstances if you are not present in the moment and perform a microsurgical dissection to preserve the nerves. Then after that, as a secondary repair, it's very difficult to repair this kind of nerves. This is also related to neurofibromas, which are associated with neurofibromas type 1. This is also a nerve which is also very interesting in physiological anatomy. It's a dorsal branch of C2 of spinal nerve. This is a great occipital nerve. It is for sensitive innervation of the occipital region. Entrapments can be reason of the occipital neuralgia, and differential diagnosis can be quite difficult, considering headache, myofascial pain, vertebral disease, cervical spondylosis, pain from hearing one malformation. Possible causes of nerve entrapment can be due to the trauma, to the traumatic cervical extension, fractures of the upper cervical spine, atlantoaxial subluxation, hypotrophic C1, C2 ligament, neuromas, arthritis, and C2, 3 psychophysical joint. These are some conservative measures for treatment of the great occipital nerve entrapment, but this is also now very popular surgical procedure, decompression of the greater occipital nerve entrapment as a part of migraine surgery with typical approach through the anatomical landmarks for the occipital nerve, great occipital nerve, but also migraine surgery can be done with the decompression of all other nerves which are extracranial. This is for example, the compression of C2 nerve root and the compression of atlantoaxial fusion. In idiopathic cases, there are some surgical procedures, including implantation of the occipital nerve stimulators, but generally speaking, this can be very complicated in this situation. Greater occipital nerve schwannomas is also one of the lesions which we faced on this. This is a nerve which is not repairing. This greater occipital nerve is not repairing in terms of grafting procedure because it's a sensitive nerve, so major surgery is decompression surgery. Mandibular nerve is another nerve, and these are trigeminal nerve schwannomas, which are most common and with a different type of presentation. This is for a multidisciplinary approach together with the maxillofacial surgeon, but the lesion of the trigeminal nerve is also very difficult to repair. This is the nerve which is most commonly repaired when we are talking about nerve repair in nerves around craniovertebral junction. So this is facial nerves. So anatomy systematization is mandatory, and the knowledge of this is a key in temporal and extratemporal landmarks is essential for accurate physical diagnosis and safe for effective surgical intervention. So facial nerve paralysis is very well known, and etiology of facial nerve lesion can be different from congenital to the iatrogenic. Location of the facial nerve lesion, which can be surgically repaired, starting from the cervical-pontine angle, then on the petrous bone, stylomastoid foramen, parotid gland, and within the face. In stylomastoid foramen schwannomas, when you remove these schwannomas, you are facing the facial nerve, which will be ideal to be identified and to, let's say, preserved and to leave it as lesion in continuity for possible spontaneous repair. But if not, some kind of additional repair can be done as a secondary repair. This is another example of stylomastoid foramen schwannomas. So facial reanimation requirements should be done as soon as possible. Deficit is considered irreversible after 12 to 18 months. After that, nerve repair is not taken into consideration. Secondary procedures within the plastic surgeons are through dynamic reconstruction and static reconstruction, which is a part of surgical treatment of facial reanimation. But these are the possibilities for nerve repair of the facial nerves. So this is intracranial nerve grafting cases. So when you have a possibility to have a proximal and distal part of facial nerve within the CPN angle, then intracranial extracranial anastomosis, this can be done also. Ideally, should be done during the same surgery after the removal of the schwannoma, the CPN angle. Then intracranial intratemporal anastomosis are also viable options in this situation. Nerve transfer is then extracranial procedure, and these are facial nerve transfer of the hypoglossus, of the accessorious nerve, of the phrenic nerve, and other transfers in this situation. So this is direct repair, which is ideal, without tension of the suture line. Extracranial grafting. This is a reconstruction of the facial nerve when you use sural or auricular nerve grafts in these circumstances. And hypoglossal nerve to facial nerve is most common procedure for extracranial reconstruction of the facial nerve in this with all these pros and contras. Even advancement of these techniques can be let's say, done in nowadays surgical repair of the facial nerve. Direct anastomosis of facial nerve and hypoglossal nerve. This is in the case of late facial nerve repair as a possibility after, let's say, 12 months, between 12 months and 18 months. And these are some transfer modifications, including Professor Sami's modification, which are done extracranially. And these are some possibilities for end-to-end, end-to-side anastomosis hypoglossal to facial in this situation. So these are different type of translocation modification of the hypoglossal nerve transfer. Then there are another possibility, mesenteric facial anastomosis in intratemporal translocation of the facial nerve. And there are dynamic reconstruction done by the plastic surgeon, as well as static reconstruction, which are also in a domain of the plastic surgeon. So early delayed reconstruction is very important to have a collaboration between the all disciplines in these circumstances in terms to find the best possible solution to obtain facial reanimation. These are the examples for the vestibulocochlear nerve and vestibulocochlear nerve schwannomas, which has already mentioned and will be mentioned. This is after removal surgical strategy for vestibulocochlear nerve repair is quite controversial because there is no possibility for this in even intracranial or extracranially. Also for the glossopharyngeal nerve, especially for the vagal nerve. These are not, let's say, recognized cases for this kind of nerve repair. Accessory nerve is a nerve which can be repaired quite satisfactory, and these are some rare locations of the schwannomas in the jugular foramen and with clinical presentation. So this is also possibility for lesion of these cranial nerves. Some of the situation for the vocal fold paralysis, the most frequent cause of the trauma is recurrent to lateral nerve, can be also done in terms of nerve repair and nerve transfer, using ansatz cervicalis to make a nerve transfer to the to regenerate the recurrent laryngeal nerve. Also using hypoglossal nerve in this situation when we have a lesion of the hypoglossal nerve and sympathetic chain schwannomas. Some of the renovation can be done, including also this one with when you have a keratopathy with contralateral supraorbital supratrochlear nerve transfer in this situation. So thank you very much for your attention, and I cordially, this is my mentor, Professor Samaric, I cordially invite you to come in Belgrade to join us for the most exciting scientific event this year in Europe and beyond, neurosurgery, beyond technology. Let's see you in Belgrade. And this is an invitation for our annual meeting, Serbian Neurosurgical Society annual meeting in December. This is my family. Thank you very much for your attention.
Thank you, Lucas. Thank you so much. I don't know if there is any question from the panel. May I ask you something, Lucas? Is there, maybe the question is too simple, but I need to know if you have any intraoperative neurophysiologic test that make you predicting if you are going to have a good result or the chances of good results is going to be higher.
Intraoperative neurophysiological monitoring is mandatory. I'm talking now from the position of the surgeon who will do nerve repair. If somebody invites me to make a microsurgical anastomosis, for example, facial nerve or extracranial, intercranial, or intracranial during the surgery of the after surgery of the lesion of the facial nerve after surgery of the schwannoma of the CP angle. This is a surgical strategies or techniques for this kind of surgery. Ideally, when you have a preserved nerve, you of course you are using intraoperative neurophysiological monitoring. But when you have a lesion with without continuity, when you have a nerve section, this is a problem how to do it, especially for the other particular nerves which are not so, let's say, good for nerve repair, such as facial nerve. Facial nerve is very good for nerve repair if you have a lesion with continuity, with let's say disruption of the nerve, and then you can make a fine reconstruction of the nerve and expect to find recovery following physical therapy and stimulation during that time. But some other nerves are not, and no matter if you are using intraoperative monitoring for microsurgical dissection of the tumor or whatever, if the nerve is disrupted, you cannot, for example, make a nerve transfer for a vagal nerve, or for example, some situation for a trigeminal nerve, for example.
Thank you, Gus.
Lucas, can I ask you a question? I had many years ago a regretful complication where after a large vestibular schwannoma resection, at the very end, when I tried to take off the last bit from the nerve, I created a thermal injury to the nerve. And the question was, because it immediately stopped working, what to do at that moment? Is there any, because the signal was lost and I wasn't sure what the outcome would be, is there any role that you think to excise the segment that is thermally damaged? Should one wait? Is there any good advice? Is there even a role for an interposition graft, which I think must be technically super complicated, but do you know?
Yes, you mean during microsurgical dissection?
Yeah, at the very end, you know, it's a typical mistake when you think perfect is the enemy of good. I had done a fantastic resection of the large tumor, and then like a 1 millimeter piece was sitting on the nerve, and I, for whatever reason, buzzed it, and the nerve died right there, functionally, right? And 6 months later was minimal recovery.
Well, this is a matter of, let's say, personal feeling of the surgeon, you understand me? And it's a matter also of, if you lost the signal, my advice will be to either to wait and see how it will work. Either the signal will repair and then to continue to remove the tumor, or if not repair, then it's another story. You can either remove it and reconstruct the nerve, or but if you have a small piece of the which is a very small piece on the nerve, and you lost the signal, I would not insist in removing that piece in these circumstances. Spontaneous cranial nerves are different than extracranial nerves in terms of they don't have same quality of epineurium and endoneurium, and is different perineurium is different. So regeneration of the cranial nerves is going quite differently than extracranial peripheral nerves. So cranial nerves, when they go extracranial, they are peripheral nerves, or despite they are cranial nerves within their cranial part. Then they receive the characteristics of the peripheral nerve, like all other peripheral nerves in the body. But when you are talking, if we have a lesion in intracranial, this is a very complex situation to reconstruct this, or to make some kind of nerve repair in terms of nerve transfer in this situation. So the better is to preserve the nerve.
Anybody else on the panel ever had an attempt to intracranially work on the nerve?
Once again?
Yeah, I just wanted to know whether anybody else on the panel has any experience or ever attempted to repair the nerve intracranially. Extracranial makes a lot of sense to me, but if you lose the signal at the stem.
For example, I am invited sometimes from the ENT surgeons When they have an intrapetrosal part of the tumor, which they are removing through their approach, and this is a facial schwannoma, for example. And this is also very tricky situation when you have to make a micro dissection of the schwannoma to do the facial nerve in that part, using intraoperative monitoring and everything. But if you are not able to preserve the nerve, or they made the lesion of the nerve, I reconstruct the nerve immediately at the same stage. I may put a graft 1 centimeter, 2 centimeters proximal distal anastomosis using Beriplast, and that's it. And you receive quite good results of recovery, because immediate repair is the best option for this situation, comparing to secondary repair when you use hypoglossophacial anastomosis or other thing.
I think your question is, if you burn the nerve, but there is still anatomical continuity, the dilemma is whether to repair it on or resect it and anastomose it or to leave it. My preference would be, if I think there is some element of continuity and some viable tissue there, probably not to do anything further and wait and watch.
Yeah, because you almost anticipate there will be a glial scar from the thermal injury, right? So maybe there's a chance for some fibers to bridge.
Go through.
Yeah. Okay, thanks.
Isn't it always that the complication is at the end of surgery?
After a long day.
Yeah.
So I think we are ready, Imad, to go for the next part.
Move to the next session. I think Vladimir will lead on this moderation for the second session. Vlad.
Okay. Hello, everyone. It's a pleasure to see you all. It's great. And not to lose time, I will just ask Francesco Tomasello to give a lecture on tuberculum cell meningiomas. Francesco, floor is yours. Hello.
I start to share my screen. Can you see the screen?
Yes, make it like a presentation mode, please.
This is for me. It's a presentation now.
It is. It's okay.
Yeah, it's
Go
fine.
ahead, please.
Is it fine or not, Vladimir? Can you see the screen, the full screen?
Yes. Yes, everything's all right.
Okay. Thank you. Okay. Thank you. Thank you, Vladimir, and thank you, Imad, for inviting me to take part in this webinar, which is a tribute to our great friend, Fred Gentili. I had the possibility to touch with him in the last months, also in the last months of his life. And in the last weeks, we had some Zoom private meetings just to stay close to him and to share with him his thoughts and his feelings. Fred,
sorry, Francesco, to interrupt. Francesco, sorry to interrupt you. I want to get your permission and the other members of the faculty that Mrs. Gentili, Gina, she is very adamant to attend that sessions. She will keep quiet, she said, but she would like to hear your presentation.
Oh,
is it okay with?
Thank you. Thank you.
I think it's
we were together with Gina and with Fred, and he was, as we know, not only an outstanding neurosurgeon, he was outstanding also from the human point of view. His philosophy is really amazing for every one of us. And I can't forget that he was bestowed and he came with Gina to the University of Messina to receive the gold medal of the university. We spent a very enjoyable time, and he gave some lectures which remain memorable for every one of us. So I consider Fred one of my closest friends in the international community, and we were always together, and he gave me many advices, and I gave him some advices. So it was a great relationship, and it will remain a great relationship also with Gina for the future. This is my message. My talk, as you know, is on tuberculous-musella meningiomas. I had several discussions with him about the best approach to tuberculous-musella meningiomas, and there was he was completely and intellectually honest and wise in recognizing the advantages and disadvantages of each of both approaches, endoscopic endonasal and transcranial approach. And of course, as we heard just a short time ago, he had a great knowledge of anatomy, and he was able to operate, as we know, from above with the transcranial approach and from below with the endoscopic approach. So the anatomy is very important. We know that this tumor impairs mainly the visual function for his position, and the may in case also the ICA, ACA, and their branches, and very important also in these cases is the pituitary stalk. And from below, we already saw some very nice images from our friends as Henri Schroeder and Rudi Falbusch and so on, about the perspective from the nasal approach with the optic nerves, the optic chiasm, the pituitary stalk, on prechiasmatic view, but also in subchiasmatic view, as we saw already with the presentation on craniopharyngiomas. As we know, from the transcranial approach, there are different routes which can be used, and transnasal or endoscopic endonasal, and sometimes we need a combined approach. Which are the goals of surgery? Preservation of or improvement of vision, reduction of morbidity and mortality, of course, total removal of tumor to avoid recurrences, and the essential choices, and this was my discussion often with Fred, is about the appropriate approach, or what we think is the appropriate approach, transcranial for some cases, or endoscopic for others. And also, we can't forget the role of radiosurgery, also for some remnants or recurrences in some cases. This is one comment of the Fred Gentili and Almeida on grading scale for tuberculous-musella meningiomas. And these are the really thoughts of and the sentences of this paper, talking about endoscopic endonasal versus transcranial approach. The different characteristics of the patient selected for each approach preclude any valid comparison of results. Endoscopic endonasal surgery in the opinion of Fred Gentili, should be reserved for selected small midline tuberculum meningiomas. But open approaches remain the approach of choice for most meningiomas for the majority of surgeons. Which are the criteria of choice? In his opinion, tumor size, extension, optic canal invasion, and vascular encasement should always be considered in the surgical decision making. But the comment was to the paper of McGill and other also Italian contributors. And in this case, the criteria of choice for were tumor size, optic canal invasion, and arterial encasement. This is a paper of the same year, but 3 years later, in this paper of Youngerman, the criteria for resectability of tuberculum cell meningioma with an endoscopic approach is the extent of tumor lateral to optic canal, not generally this tumor size, but the extent lateral to optic canal, the complete encasement of ICA, and prior surgery. There was a change, as you see in the criteria for to decide which kind of approach to use in these cases. But if we speak about transcranial approach, we have pteryginal, mini pteryginal, as you know, but also we see in the literature the use of subfrontal, anterior interhemispheric, supraorbital, fronto-orbido-zygomatic, but usually I use pteryginal or mini pteryginal approach, and of course, on the other side, endoscopic endonasal. We have surgical steps in transcranial approach. We know exactly for all meningiomas, the vascularization, the bulking, the compression of an optic nerve, preservation of the small arteries from the ICA, if we reserve the arachnoidal layer, which is very important, as we know, in the meningioma surgery, preservation of the anterior communicating artery complex, removal of tumor inside the optic canal, of course, through an unroofing of the optic canal, and dural attachment removal. We can't, the transcranial approach, the pteryginal approach, will require to have a wide opening of the sylvian fissure, just to reduce the potential retraction damage of the frontal lobe. This was a classical tuberculum cell meningioma. I was convinced, as you see, that there was an encasement or an invasion of the ACA in this case. So I decided to operate this case by transcranial approach. Anyway, in this case, there was no encasement of the anterior cerebral artery, and the dissection of the tumor, of course, utilizing the arachnoidal plane from the optic chiasm and from the optic nerves was more simple than we expected. The protection of the optic chiasm and the as you see here, the preservation of the pituitary stalk, both optic nerves, of course, and it's possible, in my opinion, with a pteryginal approach to remove exactly. I don't need an interhemispheric approach, just go from upside to the tumor, and this is, of course, the postoperative control. And this is a classical case that probably can be operated by an endoscopic and nasal approach. This is what we think. But of course, in this case, there is no doubt that an open approach and transcranial approach should be better. And you see here that is more vascularized, and here we need to speak, but I have not enough time because we talk about meningiomas, but meningiomas are different for with reference to consistency, to vascularization, of course, also with reference to position and extension of the tumor. And you see here the dissection from the optic nerve and the removal of the tumor through the optic carotid window with protection of the carotid artery and the protection of the anterior part of the optic chiasm. And at the end, we see that, of course, we have a preservation of the pituitary stalk and arteries and a good view of the anatomical region. And this is the postoperative control. But I think that when we use a transcranial approach, especially pteryginal approach, we need to take into great consideration the microvasculation of the optic nerve. You know that there is a great debate with which approach we have a better visual outcome, and we say also, I have a slide on this, that endoscopic endonasal provides us better visual outcome. But if you go, we need to see the small vessels of the optic nerve, because sometimes the damage of the optic nerve, it does not depend on the mechanical manipulation, but by damage of the microvasculation. So this is the ICG video angiography in this case. Recurrence. Unfortunately, one of the most frequent recurrences is the meningioma in the optic canal. And sometimes it was my mistake, because I was convinced that the unroofing of the optic canal is mandatory just to manipulate better the optic nerve, but also to be sure that you have a radical removal. In this case, the unroofing was made, of course, and the tumor was resected from the optic canal. And this is the postoperative control in this case. But let's go back to the sentence of Fred Gentili. Small midline tuberculum cell meningiomas can be absolutely operated through an endonasal endoscopic approach. And this is a case, of course, is absolutely normal for with the extended exposure and as you see here, we do not consider the adherence of the tumor. In this case, there was no tight adherence, and the small tumor was removed. As you see, the view of the optic nerve and the chiasm, and also the preservation. This is a technique which preserves also the microvasculature of the optic nerves. But we don't know exactly always what kind of a meningioma we have. Consistent, vascularized, of course, we know. And the adherence, sometimes we don't know enough. And this is the postoperative control. And this is the visual field postoperatively in this case. Of course, there was an improvement of a visual outcome. This is my experience with anterior skull-based meningiomas. I operated 46 tuberculum cell meningiomas, most of them by transcranial approach. Recurrence, in my experience, is 10.7%, in about 8 years of follow-up. And sometimes when you have a remnant or have a recurrence, especially when this is growing, the radiosurgery may be an important tool for these cases. This is a cyberknife we have in the University of Messina. And this is a case treated by radiosurgery. And as you see, there is no damage, no injury of the optic nerve. But if we look at the visual field, we see that there is an improvement also in the visual field, and the remnant was absolutely well controlled and treated.
Francesco, 2 minutes, please.
I am going to the conclusion, my dear Vladimir. The endoscopic, which conclusion can we draw? Endoscopic approach is associated with significant postoperative visual improvement. This is well known. CSF leaks are significantly higher in patients undergoing endoscopic compared to transcranial. Of course, we had different strategies and closure techniques, and the CSF leaks now is approximated, because it's variable in different series, approximated 5%. There are, anyway, all the studies are retrospective studies, no randomized controlled trials, and probably it's difficult to have such type of investigation with the surgical techniques. This is what was stressed in the recent paper of this year. And the recurrence rate is 10% without any difference between transcranial and endoscopic approach. And this is the last slide. Transcranial approach should be considered the standard approach for tuberculum cell meningiomas, as Fred told me several times. Endoscopic endonasal approach in selected cases, but we know what we mean as selected cases, different characteristics of tumors, extent of expansion, and so on. There is anyway no significant difference in gross total removal and recurrence rate between both techniques. Visual outcome is without any doubt better in endoscopic. In transcranial approach, in my opinion, visual damage may depend on injury of microvasculation. Section of a falciform ligament early and the roofing of the optic canal may be essential for optic nerve decompression. I think that it's impossible.
Francesco, please conclude.
Till now, it's impossible to say what is better. Probably is possible to say what kind of approach you can use in an individual patient. Thank you so much for your attention.
Francesco, thank you very much. We have time for one very short question with one very short answer, please.
I make a small comment, Vladimir, in that case, nobody's asked.
I'm sorry, but we can comment after Jacques. Should he be on time, then we shall have some time for discussion of both, because I suppose, Jacques, the topic is very similar, isn't it?
It's absolutely, yes, I agree.
Yeah.
Vladimir.
Okay, so let's go to the next. Yes, Imad, please.
Well, sorry to interrupt you. I know we'd like to be on time, but we have a special occasion that Gina Gentili has joined the podium, and on recommendation of someone members, if we can give 2 minutes short statement to Gina from you guys. And Gina, are you with us?
I am. I'm right here. Thank you. Can you hear me?
I'm glad to have you here. Well, you are welcome. And you see, all of us, we have him in our heart and on our mind. And we talk as he is with us. And now we have the opportunity. We have the Eastern, the Ramadan, and the Passover, all religion, whoever coming from any religion, from any sector, and the neurosurgical family, pray for him that God embrace him with his mercy and put him in paradise. And you have a family behind you. And I don't want to be dramatic and expedite, but I'd like to give the opportunity to Pablo, to Vladimir, to Francisco, to Professor Falbush to give few statements to you on behalf. They have spoken a lot of Fred, and they keep Fred pictures and philosophy on all their presentation, but we give them the chance. And of course, our friend Jack Mo, because he and myself, we were very close to him. And of course, all of you, they are friends, but for the sake of time, we will just cut it short this way. So I start with Pablo.
Hello, Gina. This is Pablo from Spain. I just want to...
Pablo, sorry. Pablo Cababianca. If you can say a short statement to Gina.
Fred is with us, and it's beautiful to have Gina keeping his memory alive. Thank you for coming, and God bless you.
Thank you. Thank
you. Falbush. Unmute yourself, please, Rodolphe. Unmute yourself.
Yeah, now you can hear me. So I met Fred before your time, Gina. So we personally didn't have so many contacts, but I've met him over many, many meetings. And for me, during his presentations, he was the master of the detail. So we presented so many details that it sometimes confused us. However, I would say he was a master of representative details. So these details counted forever. And I hope this will be the same in your life, and we always keep his memory awake. Thank you to be with us.
Thank you. I deeply appreciate
it. Gina, as you know, we miss too much Fred. And we thank God because we will have the opportunity to meet you once again and to have together memories. And through the memories of Fred, we are sure that Fred continues to live in our heart.
Thank you.
I think Giovanni wants to say something.
Well, it was a real pleasure to have you here. And I think that Fred will always stay with us and live with us. And we were very near to you and to your family. Ciao.
Ciao, grazie.
I know Thomas was very close as well. Tom, you want to say something?
Thank you very much, Imad. In fact, I was typing an email to Gina just now, so this saves me my slow typing. Well, great to see you, and I'm delighted that this community could organize this very special meeting, because there's been lots of people, particularly in this community, who highly respected and loved Fred, not only because he's been a great and honest surgeon, but as everybody else said, great human being, and very inspirational to me personally.
Thank you. Appreciate that.
The final statement, we'll leave it for Vladimir, but Jacques, he will take it from his presentation when he was talking about the presentation. Vladimir?
Okay, I'm sorry, Imad, that I rushed the lectures forward. I didn't know this. Jacques, I believe that you will talk about Fred at the beginning of your lecture. So I will just shortly. Gina, I remember when you were first time in Prague in 2007.
Yes.
European skull base.
That's
And I
great.
just ran across an old photograph where there is Eva dancing with Bernard George and Fred. And that was very sad seeing this image really. But what I would like to say, that there was not a single sentence from Fred I wouldn't listen to, and there was not a single sentence which would be useless. He was really great teacher, great surgeon, great friend. Happy that you are with us.
Thank you.
Now the other things I want to let you know, Gina, we have Pablo from Spain. He was with us on many occasions. We have Igor, he is Brazilian, born in France, Igor Maldonado. We have Victor Hugo from Mexico. We have Sanjiva. I have difficulty, your family name, Jacartina, yeah, to pronounce it, from England. We have Ek is very close, Casper. And we have Dr. Takashi Kon from Japan. And of course, on the top line, I'm seeing my eyes comes down. Now I'm lifting them up. I have Professor Ramesh Nair, very close friends from England. And all of them extend their regards to you and prayers to Fred. I think we will take, if you don't mind, Gina, we'll let you have one word, final word, but we would like to take one picture in the group. I think Pablo will help us taking that picture, if you don't mind.
No, I don't mind, with pleasure. And let me know if I can say one word whenever.
Sure. And I'd like everybody to have a smile. We want to send this smile to the upper level, now that keep it in the air where the fight's still going on. All right. Are we ready, Pablo? Oh, you took it already, a picture? Okay. Okay, Gina, it's your call.
Everybody, I would just like to quickly, profoundly thank you for remembering Fred and his contribution. You are truly wonderful friends, and I know that wherever Fred is, he's looking down and smiling, paradise for sure. And, you know, when Fred transitioned from doctor to patient, he taught even more in his grace, and he set his example. He actually said to me, I'm happy that this has happened to me. I said, what? He said, I'm happy because now I can profoundly understand what it's like to be a patient. So he had a well-rounded understanding as a neurosurgeon and as a patient, and not only that, as a human being and as a dear friend to all of us. So on behalf of Fred, thank you profoundly for remembering his lessons as a surgeon. I learned lessons from him not as a surgeon, as a human being, but as a patient, as a person. And he set no finer examples. So thank you very much. And I profoundly appreciate this. It means so much.
Thank you, Gina. Thank you for being here. You are privileged to stay with us and to watch the other talks. And I go back to Vladimir to run the moderation. And we have listening ear for Jack.
All right. We should stand up and keep a minute quiet, but I believe that Jacques will start his talk with some memory and some introduction about Fred. Jacques, floor is yours.
You know, if I knew Gina was going to be with us, my whole talk would have been on Fred. But then I would have no dry eye when I'm saying it. So I do have some slides. Gina, wonderful to see you. Elegant as always. Eloquent as always. My talk is about a topic very dear to Fred, again, to continue the beautiful theme that Tomasello has talked about. But this is Fred with his mom. This is where he was born, apparently a city of 4,000 people. And if you've read my tribute to him, I think a lot of his spectacular qualities probably stem from those beginnings. This is him in medical school.
You can tell it's 70s with the hairstyle. But those are the images of Fred over the years. We all loved his smile, his infectious happiness and his smile. And here I am trying to adjust his tie because clearly Gina did not know how to dress him. He was absolutely impeccable, elegant as always. Here he is being one of his many honors, Canadian honor of the state of Ontario. I have many more slides, of course, but he is a Cavaliere. He was honored by the Italian president. And his superb judgment wasn't isolated to neurosurgery, as you can see from those images. As again, I said in my tribute, we came for Fred, but we stayed for Gina. And what a remarkable human being Gina is. And again, I'm not going to start talking in this direction because I don't want to embarrass her, and I don't want to deprive the students who are here to listen to various talks. But I tell you what the best message of my talk is to the students, the trainees who probably did not know Fred because of their youth. I can summarize some of the qualities of Fred in his mastery, who he was, superb surgical skills, embracing most challenging cases, world-class educator. But all of that, I mean, perhaps several people I like this, but when you mix in the no-nonsense approach, this incredible transparent honesty that he says what he means what he says with humility, and that extreme sense of ethics and responsibility towards the patient. And you then add to that the layer of adaptability to change, embracing endoscopy at a relatively mature stage in his career, in his early 50s. I mean, this is quite unique. I of course loved him as a human being, as a friend, but you tend to forget what an incredibly accomplished innovator, neurosurgeon he was. And anyway, he certainly deserves a whole hour of me talking about him, but I'm going to stop here. And I've certainly given different aspects of his life in other tributes. And Gina, we've talked about him in Rio, we've talked about him in Bogota, and we are not stopping, because as long as there are unique people like him in our field, that's really the legacy. Yeah, I mean, the talks we all are giving now are very important to our students, but our students need to understand the human dimension of what makes some of us neurosurgeons, human beings, really great. And those are the human qualities that Fred embodied. I do feel sorry for the young people who did not know him, and I feel very lucky that I have known him for 20 odd years, like many of the other speakers here who've known him even longer. So there we go. I am now going to the boring part of the talk and talk about meningiomas. Gina, of course, you're welcome to stay the whole thing, and we're welcome to leave whenever we start boring you with the neurosurgical stuff. So let me talk about, I'm going to try to be provocative. I do not have the quality of Fred of complete equanimity. Fred and I slightly disagreed on this topic, but obviously that's why I'm discussing it today. This is Scott's parabola, what happens to innovations. I am not against adopting a new surgical strategy if it makes sense, if it's proven superior. I love endonasal endoscopy. I've applied it. Not as much as Fred, but I've adapted over the years. For example, most craniopharyngiomas I would do endonasally today. I used to do them transcranial. This is a typical case, pre-op, post-op. These cases, juvenile psammomatous fibroma, of course, endonasal is the way to do. This is intra-op views, post-op. Orbital apex schwannoma, medial to the optic nerve. Of course, endonasal is the way to go. I used to do them cranio-orbital, unnecessary. These are almost outpatient, well, they are outpatient procedure. You could send the patient home that evening after this endonasal approach. Most clival chordomas, I do endonasal. This is a view. This is post-op. But I feel very differently about anterior skull-based meningiomas. They are either olfactory, planum, or tuberculum. Why? There is a lure of marketing. There is a slight dishonesty, I'm going to say, in the way it's marketed. People say it's non-touch technique. It's garbage. It is touch. We don't touch the skin, but we destroy the nasal mucosa. It's minimally invasive. No, it's not. It is minimal access surgery. It's maximum invasiveness. No craniotomy, that is wrong. It is a craniotomy, as we all know, it's a craniotomy through the nose. We're opening the skull. Concealing the craniotomy does not give us license to conceal what we are actually doing. This is from the literature. Yes, you can absolutely remove these tumors through the nose, but that's a post-op. That's a craniotomy. Why not call it by what it is? It's a craniotomy through the nose. Actually, the craniotomy is larger, the bony defect, than you would through a lateral supraorbital approach, which you could do to remove this if you're going to do it transcranial. That's a view endonasally, certainly can be done. That's another case from the literature as well. It's a craniotomy. That's what it is. Just let's be very accurate in our literature. Let me show you some older literature. Olfactory groove meningiomas. CSF leak rates, 30%. This is from 7 years ago. Look at the new seizures, brain abscess, hydrocephalus rates. Gross total resection was only 66% done endonasally. 2018, transbasal versus endonasal. This is the data. Again, shows in a transbasal approach remains the workhorse for removing large and complex tumors, particularly with lateral expansion. Systematic review 2017, olfactory groove meningioma. By the way, I actually omitted a beautiful paper by Fred proving my point because I have such limited time, but Fred published a very nice, very well done paper showing that the transcranial approach was still the gold standard, although of course he espoused endonasal in some cases. That meta-analysis shows transcranial was superior. Logical conclusion, in my opinion, for olfactory groove and planum, transcranial is clearly superior. I don't really think there is a reasonable debate, if we're going to believe the data that we see, that is the case. Where the controversy is, it seems, is in tuberculum sella. So what does the literature say? I'm skipping several slides to try to stay on time. The vision does seem to be better with endonasal, but CSF leak rate is higher. However, in those early papers, the volume of tumors removed endonasally were much smaller than the ones done transcranially. This was Paul Gardner commenting on that paper and criticizing it. Our friend Henry, I don't know if he's still on the panel right now, in 2014, Henry, who, as you know, is a spectacular endoscopist, in his opinion, most meningiomas, the endonasal approach has no advantage compared to the transcranial approach. 2019, transcranial versus endonasal meta-analysis. This is interesting. Look at where the residuals tend to be with the transcranial approach. Endonasal. They're lateral. People are missing tumors plastering the dura over the clinoid or the lateral wall of the cavernous sinus. Sam Al-Mafti talked about this decades ago. If we accept that this will happen, then let's keep doing those endonasally. But that's where the easy portion of it to remove is when you do it transcranially. Now, it doesn't mean transcranial, you don't get recurrences. You do if you're not aggressive in the midline at drilling the hyperostotic bone, such as this row of cases at the top, recurrences versus after endonasal at the bottom. Tuberculum meningioma 2018. Again, Henry talked about add the endoscope as an assisted technique to transcranial through an eyebrow incision or lateral supraorbital. We can debate what incision, and these are less important factors. Visual outcomes in his series were excellent with that technique. Meta-analysis in 2019 showed that to be the case. European Skull-Based Society guidelines in 2019, again, I'm not reading all that, but supports that the gold standard remains transcranial approach. I am going to skip some more literature. This is a contralateral approach that you could use sometimes. I apologize if I'm running. I really want to keep us in time, so bear with me. Here, a more extensive meta-analysis bears a lot of the points I just made for all those, and I refer you to this paper if you'd like to read the details. We have combined our series with Pittsburgh. This is not published yet. This is Stephanie Chen, our chief resident. Most of our cases are transcranial. Of course, most of the Pittsburgh series is endonasal. We looked at tuberculum sella, 59 transcranial and 30 endoscopic endonasal cases, total 89 cases. Look at the mean tumor volume. In the Miami series, transcranial 15 cc's. In the Pittsburgh series, 5.6 cc's. A third of the volume were done usually done endonasally. How did we do? I am going to go straight to the results. There is no statistical significance in difference in stability of vision, improvement, or deterioration of vision between the two approaches. If you do multivariate analysis, yes, there is a superiority of vision improved with endonasal. And that point keeps coming back. The problem is you cannot handle the huge tumors endonasally properly. So I'm looking forward to analyzing this data further to publish it with Paul Gardner and the Pittsburgh folks. Interestingly, endonasal, there was 4% risk of hematoma post-op. And of course, the length of surgery is 40% longer. This is in the hands of masters with the endonasal approach compared to the transcranial approach. My logical conclusion with tuberculum sella meningioma, the vision outcome may or may not be better with endonasal, but all the other factors favor transcranial. And I believe transcranial is clearly superior to endonasal. There are exceptions. I think a recurrent tuberculum sella meningioma after transcranial surgery, if it's in the midline, should be done endonasally. That is easier. Or of course, if it extends in the paranasal sinuses. Why do I say that? You look at a case, simple case like this, many people would do it endonasal. I don't know about many, but several people would do it endonasally because I would say, look, the tumor is medial to the optic nerve. I think it would be a mistake. I did this case like I normally do them, lateral supraorbital. And I'm going to show you why it's a mistake. Because the tumor, as Sam Al-Mafti has said, spills over lateral to the optic nerve. And when it does that, you are going to not achieve a good Simpson grading, scoring. And look at the tumor inside the canal. Look under the optic nerve. Look at the adherence to the superior hypophyseal artery branches. And I've achieved a Simpson grade 2. That's really the best you can achieve if you count that you cannot really resect the dura all around the optic nerve. But that's the best you can do transcranially. Or another case, Maybe people would do this endonasally, even though it's engulfing the anterior cerebral complex. That would be a mistake. I did this also transcranially, and I'll show you operative pictures. Just imagine doing this case endonasally. Look how engulfed. There is one specific picture I'm going to take you to. The hypothalamic perforator, the superior hypophyseal artery, completely engulfed in the, look at it, in the middle, look at it, in the middle of the tumor. Just imagine dissecting this endonasally. It can be done. It's very awkward and it's not safe. Because of the instrumentation that we have today, I'm sure things will change over time, as Pablo talked about earlier. This was very hard for me to remove, and I'm doing this open. I mean, this was really a struggle, but I did achieve a Simpson grade 2 by the time I finished. I think I should reach my conclusion. I'm sure I'm out of my time, so bear with me a second. So I put us back on time. I was going to show you cases that get blinded, done endonasally, done at other institution, and with incomplete resection. So that's my problem with doing it. So just to make some fun of the whole topic, this is the view from below. You lose accurate perspective. It's a rather uninviting view. The ugliness is near, the beauty is far and out of reach. Who wants to see something like this when you can see it from heavenly, celestially from above, like Fred is looking down at us from above, from, if there is a heaven, certainly Fred is the first one up there, versus this terrestrial view from below. Open approach is so much better due to access, manipulation, resectability, and the ability to have less CSF leak and ability to reconstruct. I believe sellar lesions are at the top of Scott's parabola. I believe anterior skull-base meningiomas are going down Scott's parabola of innovation. I hope aneurysms never reach the top of Scott parabola in doing them endonasally. And let's remember, a fool with a tool is still a fool. Fred Gentili, boy, do I miss you. Thank you very much for your attention. I'm sorry.
Excellent. Thank you. I can tell you that we actually went directly along the Scott parabola. We started in 2007, thanks to Paolo and Pittsburgh group. Then we started doing meningiomas endoscopically. And by now we are doing all of them transcranially. We completely abandoned meningiomas endoscopically, unlike craniopharyngiomas. Is there anyone who would like to discuss both Francesco's and Jacques' lecture? Paolo, please.
I listened with attention to everyone. First of all, Jacques Morcos. And obviously, I disagree with many of his statements, respecting him and his work, because we need to know really, to inspect the complications. And I am sorry to tell you that in the last 101 extended approaches, we got just one CSF leak. And I am sorry to tell you that I have seen CSF leaks also in the transcranial approach. So these data, all of you present quite often, do not correspond to a wise use of present reality, as we have done, including Fred and other people. So there are options to be used wisely, and transnasal approach is one of them. And some more are coming, including transpalpebral and supraorbital. There is room for everyone. The important is to be as wise as possible to do the best thing for the patient.
I think Henry has his hand raised, no?
Yes, sure. Yes, thank you so much for both presentations. And I think the major problem, Paolo, is that the meningiomas have frequently unplugged grow laterally. That is what we see very frequently with medial sphenoid wing meningiomas. We see it with olfactory groove meningioma. And that is a problem that I think the recurrence rate in the end will be higher with endonasal. I completely agree with you that there are some indications where I also make endoscopic endonasal better than transcranial approaches. For example, when the skull goes very steep down, sometimes it goes 2 centimeters steep down, and then you can reach it much better from below. But in the majority of cases, I feel that it is safer for the patient and also more convenient for the surgeon to make it transcranially. For example, when the meningioma is infiltrating the adventitia of the anterior cerebral artery complex, which is frequently seen, even if you think there is an arachnoid plane around, you never know exactly. You see it only. You can argue, of course, I can deal with it from below as well. That's true, but it's a safer and faster, at least in my hands, when I make it transcranially. So that's why in meningioma, in most of the meningiomas, I think the transcranial approach is the best, but it should not only be it. There are some indications where I agree with you, the endonasal approach is better.
Francesco, yeah, Francesco, please.
I would like to, I agree almost completely with Jacques about, because also in my presentation, I am particularly in favor of a transcranial approach. But I would like to say to Paolo, can you hear me? Paolo? Yeah, yes.
Yes, I am.
What we know at present about gross total removal and recurrence rate is that there is no difference between transcranial approach and the nasal approach. The only effect which is really very stressed is the visual outcome. But Paolo, we compare different tumors. When we speak about the tumors, the meningiomas, of course, I speak about tuberculum cell. Meningiomas treated by endoscopic are different from the tuberculum cell meningiomas treated by transcranial. And this can happen now. Is almost in my experience, in my knowledge. So I think that of course it's possible to have a randomized controlled study, and we of course do not consider the endoscopic approach an useful approach. I said the difference of my speech with Jacques is that I said that endoscopic is suitable for some selected cases, especially midline with not great size meningioma. This is my personal opinion, and Jacques showed to us that you can have meningiomas with anatomical relationships with the vessel, with small branches. It was the last movie he showed to us. That, of course, may be difficult to manage from below. You know, Paolo, perfectly that meningiomas are very different with different features, anatomical features. So this is the problem. There is no discussion. In fact, there is no discussion about craniopharyngiomas as there is discussion about meningiomas.
Francesco, I believe that Jacques proved this perfectly when compared the volume of Pittsburgh group and his group. It was really a major difference.
Yes, difference. Yes, of course.
Next thing, Paolo, definitely in your hands, the results are different than those in, let's say, common life. Your series is extraordinary. You are extraordinary in endoscopy. So it's not surprising that you have far better result than the rest of the world.
No, please. No, it's not like this. Thank you, but it's not like this. But the work that Jacques has done with the Pittsburgh group, we have done with the University of San Francisco, and is reported on Neuropsychological Focus. I agree with what Professor Tomasello said. There is no difference for the same cases, but there is not a study that can confirm this for the next future. I think that the complications referred are not anymore the one we are speaking about, and the visual outcome is better. So there is indication for smaller tumor in midline, but you can transnasally, you can also go to the optic canal medially. So when it's difficult from below, it's difficult also from above. It doesn't make difference. Anyway, it's just to discuss friendly among us. No one has the truth. So this is our experience, that's all. And I absolutely respect different opinions. I do respect.
Very, very, very good. Jacques, do you want to add something to the topic?
No, I mean, obviously, I took an extremist point of view because I certainly believe most of it, but really to push the point. By the way, I'm looking forward to Mike McDermott's multi-center analysis of like 1,000 patients. It's not published yet, and I've asked him about this topic exactly. Yeah, I do concur with what Paolo is saying. For small tumors, visual outcome is better, according to that series. Again, he's working on publishing it. He was supposed to send me the slides, but didn't send them to me. I'm actually debating this point in Philadelphia in 10 days at the AANS meeting. Maybe I'll have the data from him. The problem is you can't handle the large tumor this way. I mean, I have not seen a CSF leak rate, even in the great centers that come close to Paolo. And I mean, I know it's not false modesty, but it is not true even today, in spite of the nasal septal flap and the Napoli way of doing the layering of the reconstruction. But anyway, I don't want to keep up taking more time, but Paolo, absolutely, the respect is more than mutual, my friend.
And friendship.
And friendship.
Jacques, quick comment before you go for the debate, because you're a perfectionist and linguist. The endonasal approach doesn't do craniotomy; it does craniectomy.
I agree. You're right. Here you go. You're right.
True enough. Great, Tom. Okay, let's go further. Otherwise, we would be talking about this topic for another 2 hours. I will hand over to Ramesh Nair. Ramesh, please.
Thanks. Yeah, thanks, Vladimir. A great discussion. I'll go on to the next speaker.
Ramesh, sorry, before you go to the next speaker, Professor Landero has difficulty with the connection. So he excused himself from giving the topics. He is with us, but he cannot because he doesn't have at the hotel the connection. So you moved on.
Fine, thanks. That's fine. Thank you. It's my pleasure to invite my very good friend, Professor Victor Hugo Perez. Victor, you want to share your screen now? And if you could unmute as well. You're still muted.
Okay, thank you, dear friend. Let me share my screen.
Thank you. And the full screen.
Okay. Can you see all the screen not?
Yeah, it's not in the slide presentation mode. Can you make it full screen?
Okay. Okay. It's okay?
Yeah, it's fine now.
No.
It's okay.
It's okay now?
Yeah, it's fine. It's okay.
Okay. Okay, thank you. Thanks to everybody, especially Dr. Ayman, Dr. Vlad, who invited me to speak in this course to honoring Professor Fred Gentili. It's a great honor for me to be here with all of you. I'm going to talk about the Kawashi's triangle, and I think, first of all, it's nice to speak and to remember some things about the cavernous sinus, because it's a close relation with the Kawashi's triangle. The paired cavernous sinuses are located near the center of the head on each side of the sella, pituitary gland, and sphenoid sinus. Each sinus has dural walls that surround a venous space through which a segment of the internal carotid artery courses. The sinus extends from the superior orbital fissure in front to the area, lateral to the dorsum sellae behind. The cavernous sinus is defined as the dural space in which the cavernous segment of the internal carotid artery courses, and contains not only the cavernous carotid artery, but also a venous confluence that receives veins draining the orbit, sylvian fissure, and middle and anterior fossa, and has free communication with the basilar, superior, and inferior petrosal and intercavernous sinus. In this picture, we can see the posterior blend of the carotid cavernous artery and the meningohypophyseal trunk, the sixth cranial nerve, and the petrolingual ligament. Here is the site of the Kawashi's triangle. So the four triangles in the cavernous sinus are clinoidal triangle. This triangle is situated between the optic and oculomotor nerves, and this triangle is exposed by removing the anterior clinode process. The oculomotor triangle has two margins of this triangle are formed by the anterior and posterior petroclinoidal dural folds that extends to the petrous apex. The third side is formed by the interclinoidal dural fold that extends from the anterior to the posterior clinode process. The supratrochlear triangle is situated between the lower surface of the oculomotor nerve and the upper surface of the trochlear nerve. The infratrochlear triangle, also known as Parkinson's triangle, is located between the lower margin of the trochlear nerve and the upper margin of the ophthalmic nerve. The origin of the meningohypophyseal trunk from the posterior vein are located in this triangle. So I think there are two arteries, main arteries, that are involved in some lesions over the Kawashi's triangle. One of these is the tentorial artery, the most constant branch of the meningohypophyseal trunk, present in 100% of instances, passes forward to the roof of the cavernous sinus and then posterolaterally, as you can see in here. It sends branch to the third and fourth cranial nerves and anastomosis with the meningeal branches of the ophthalmic artery and its mate of the opposite side. Bernasconi and Casinari first reported the angiographic visualization of a tentorial artery supplying tentorial meningiomas. As you know, the tentorial artery is also known as the Bernasconi-Casinari's artery. The dorsal meningeal artery arises from the meningohypophyseal trunk, as you can see in this picture. It passes posteriorly through the cavernous sinus with the abducens nerve to reach the dura over the dorsum and clivus. It sends a branch to the sixth cranial nerve and anastomosis with its mate of the opposite side. The four triangles of the middle fossa, the first one is the anteromedial middle fossa triangle, and is situated between the lower margin of the ophthalmic and the upper margin of the maxillary nerves. The third edge is formed by a line connecting the point where the ophthalmic and nerve passes through the superior orbital fissure and the maxillary nerve passes through the foramen rotundum. Removing this triangular space, we can see the sphenoid sinus. The anterolateral middle fossa triangle located between the lower surface of the maxillary nerve, this is maxillary nerve, the upper surface of the mandibular nerve, and a line connecting the foramen ovale and rotundum. Opening the bone in the medial wall of this triangle exposes the lateral wing of the sphenoid sinus. The posterolateral middle fossa triangle, Blaschko's triangle, formed on the anterolateral side of the lateral surface of the mandibular nerve, distal to the point at which the greater petrosal nerve crosses below the lateral surface of the trigeminal nerve. This is the greater petrosal nerve, this one. And on the posterolateral side, it is formed by the anterior margin of the greater petrosal nerve. This triangle opens laterally to encompasses the floor of the middle cranial fossa. Between these two structures, the middle meningeal artery passes through the foramen spinosum in this triangle. This is foramen spinosum, and opening the floor of the middle fossa in this triangle exposes the infratemporal fossa. The posteromedial triangle, known as Kawase's triangle, you can see in this anatomical model, this skull base is made in resin. I made by myself this skull in order to understand much better the anatomical landmarks in the skull base. So here we have the trigemin and trigeminal nerve, and here the greater petrosal nerve. And to simplify, I made this in big size. Located between the greater petrosal nerve and the lateral edge of the trigeminal nerve, passes below its lateral surface and aligned along the connecting hiatus fallopi, hiatus fallopi is this one, to the dural ostium of Meckel's cave. This is Meckel's cave. The petrosegment of the internal carotid artery crosses the anterior margin of this triangle. The cochlea is located between the floor of the middle fossa in the lateral aspect of this triangle. And here you can see a dissection in one model, and we can see the third, fourth, and the trigeminal nerve with the 3 branches. This is the petrosal segment of the internal carotid artery. The Kawase triangle, the Kawase approach exposed the rhomboid fossa with Meckel's cave extradurally, the upper half of the clivus, superior cerebellopontine angle, ventrolateral brain stem, the intrameatal region, basilar apex, and the preganglionic root of cranial nerves 5, cranial nerve 3, 4, and 6 intradurally. Here we have the 3rd, 4th cranial nerve, the 6th cranial nerve, the intracavernous carotid artery, the petrous segment of this, and the petrolingual ligament in here. The basilar sinus is the largest venous connection between the paired cavernous sinuses. The superior and inferior petrosal sinuses also open into the lateral part of the basilar sinus, creating a large venous confluence along the posterior wall of the cavernous sinus. Here we have the superior petrosal sinus that is over the cavum of Meckel, so we should be very careful to not to have an hemorrhage when we are working in this Kawase's triangle. Here we have the model, and we can understand much better this Kawase's triangle. So just for simplification, the greater petrosal nerve has been placed in a large diameter in this anatomical model. As you can see here, the Kawase's triangle go to the apex, to the petrous apex. In here, I put a brain into this model. The anterior petrosectomy is designed to access the ventral and ventrolateral regions of the upper brain stem or the upper third of the clivus. This approach offers a narrow, inflexible working zone and does not allow the operator to reach large tumors. Large tumors may require a staged approach through adjuvant routes. A lumbar drain is indispensable to avoid retraction injury. The dura must remain intact until the operator intentionally opens the dura. In this picture, we can see the anterolateral aspect of the brain stem, the basilar artery, and the superior cerebellar artery. This is middle cerebral artery. If lumbar cerebrospinal fluid drainage does not allow adequate temporal lobe decompression, the procedure should be abandoned and an alternative approach contemplated at a different operative session. Forceful lobar retraction is hazardous and leads to disappointing results. The perspective of the anterior petrosal approach is to expose the ventral and ventrolateral aspects of the upper third of the brain stem. Tumors extending caudal to the internal auditory canal are not suitable for this approach, and a posterior petrosectomy should be considered to access them. Here we have the basilar artery, superior cerebral artery, the P1, P2A, and P2B of the posterior cerebral artery. Here we have some perforating branches of the basilar tip artery and the lateral view of the basilar artery. Here we have these perforating branches, and let me show you a video. So in here, I am doing a dissection of this arachnoid in order to see the posterior cerebral artery in the P2 segment. And then we can see the perforating branches of the tip of the basilar artery. Dr. Kawase looked for this region in order to get a close vision to put a clip in the superior part of this basilar artery. So in this another tumors displace cranial nerves and vessels, and injury to these vital structures during the dural opening is often most unexpected. It is okay to say there it is and be wrong 1,000 times, but it is not okay to say there it was and be right even once. This was written in Neurosurgical Atlas by Aaron Cohen. Patience is important during petrous bone drilling. Practice in the laboratory is an indispensable prerequisite for safety and efficacy of this technique. So here we have dissection. This is supracranial carotid artery, third cranial nerve, the sixth cranial nerve. The sixth cranial nerve, the trigeminal is displaced. Here is Kawase's triangle. After drilling this region, the cochlea, the auditory nerve. I remove the facial and vestibular nerves. Here we have the semicircular canals, superior, lateral, and posterior. And then we can see the ear bones, the malleus, incus, and stipes. It's very important to know the relation of the Kawase's triangle with this important neural relationships. So this is another view of this And don't forget that it's very important to work also with the venous drainage of the brain, because if we have some anatomical variants, for example, the lave drainage, the lave venous, so we could have some important risks in the temporal lobe. So in this case, this lave is in the posterior part, but sometimes could be in the middle and also in the anterior aspect of the base of the temporal lobe. So this is another.
One more minute, Victor.
Yes. This is the last video. And thank you so much for listening me. Thank you.
Thanks, Victor. Great talk. Excellent quality of a dissection. I think it's an excellent prelude to what's coming next as well. It's my pleasure to invite my very good friend, Sebastian Prolish. Sebastian, are you here? I can see you. And we'll have the discussion at the end of these two talks. Sebastian, you want to unmute and start sharing? Yeah.
Can you see me?
Yes.
Okay, so thank you very much for bringing me to this session dedicated to Fred. And Gina, I don't know if you're here. I saw you, but
I am.
Okay, it's very nice to see you, Gina. It's quite sad to think about Fred because he was a great friend. You are a great friend, and we have some fantastic souvenirs together. Fred came many times to my course in Strasbourg with Gina, and he was also the man behind this course. And I see that Jose is here, Imad. We had some fantastic time in Strasbourg together, and it was far above just scientific events. Fred was someone very special to all of us. This is a picture with Anne-Laure. She's a staff with me, and she spent 1 year, amazing year in Toronto with Fred, and she always remember of those good times, and it was very sad to learn what's happened. He was a fantastic teacher, fantastic lectures about skull-base surgery. Endoscopy was his main topic, and definitely he was a driving force for all of us, all the young guys. We didn't always agree together, but his way he was teaching, he was looking at his results, his techniques was fantastic for us. In the lab, extremely dedicated to everyone. Again, he was the course is definitely not the same without him. This is pictures of some of the faculty, fantastic interactions that we had all together. You can see that these pictures is not the same now, because during the same year we lost Bernard, we lost Fred, and for me, I have to say it was a difficult time. Again, fantastic souvenir. It was not only working for neurosurgery, but spending a lot of time together and really enjoying friendship, far above being just here for neurosurgery. This is another picture that some of you may remember that I think was taken in the world,
Dubai.
In Dubai, absolutely in Dubai. And we had a lot of fun together. And Fred was there with us. I don't know if you remember this picture, but it was a great time. So Gina, it's great to see you. And I know it must be very tough. And I am thinking about you very often. If you want at some point to come in Paris, you know, you're more than welcome to just have other type of time away from Toronto, I would be very happy. So, subject of my talk I chose today was anterior petrosal approach. It's one of the major skull-based approach that many of you knows, but it's also a complex approach that is really something for which you need to have a great knowledge of the anatomy. And we had a very nice lecture before about this piece of anatomy from Victor, and I am not going to do an overview of this anatomy, but definitely it's a complex environment. It's a middle fossa approach. So through the middle fossa approach, through the petrous apex, through the petrous bone, we want to reach the posterior fossa dura to get into the posterior fossa. It's an extradural approach. There is description of option of anterior petrosectomy intradurally. I don't think it's a good option because you don't see the landmarks the same way intradurally that you can see it extradurally. And the dura is also a protection for the brain. So you have to peel the dura from the temporal fossa floor to expose the bone, and then you expose this Kawase triangle, you drill it, you expose the posterior fossa dura, and then you have an access to the petroclival region. So again, through the petrous apex, you come from subtemporal to go into the posterior fossa. What are the advantages of it? For those complex centrally located skull-based tumor, you don't cross the cranial nerve the same way you would cross on work in between the nerve with a retrosig. It's a more anterolateral line of sight. And for tumors that arises from the dura mater, such as meningioma, you devascularize the tumor first. So you come back to the basic principle of convexity meningioma, reaching the base first. It's a nice exposure of subtentorial areas, such as the Meckel's cave, and also infratentorial areas, mid-clivus mainly. You can also see on the opposite side of the clivus, and you have a nice view of the anterior brainstem. There is some disadvantages. It's an approach that when you peel the dura from the temporal fossa floor, it's usually bleeding, venous bleeding, that can be significant. There is ways to overcome those bleedings, raising the thorax. We have now those products to control bleeding, such as FlowSeal and others. That works very well. You have to be careful with the veins. Victor showed some very nice pieces of anatomy of the veins. It's extremely important to have an idea of the drainage, venous drainage, especially the vein of Labbé on the left side. And yes, it's a subtemporal approach, so you need a significant amount of brain retraction. But again, you can reduce this retraction by some simple things to do, like raising the thorax, using mannitol, dynamic retraction to really reduce the impact on the temporal lobe. I am not using retractors anymore for anterior petrosal. So I go fast on this anatomy. We had a very nice lecture before of this anatomy of the petrous bone. The indication, I use it for petrous apex tumor like chondrosarcoma, chordoma. I did this morning, in fact, a chordoma, recurrent chordoma that was infiltrating the bone quite laterally. And I went through an anterior petrosal this time. Meckel's cave tumor, such as trigeminal schwannoma. Petrous apex meningioma petroclival is my main indication, and sometimes brainstem cavernoma. It's important to look at the CT scan. It's an approach where you drill bone. You can have an extremely precise idea of what you are going to drill, what you need to drill, looking at the pre-op CT scan. All this anatomy, neuronavigation helps, but you need to prepare yourself looking at the anatomy, shape of the temporal fossa floor, location of arcuate eminence related to superior semicircular canal. Pneumatization is like a roadmap for you to locate the cochlea, for example, pneumatization of the zygoma, descents over important structures such as ICA, superior semicircular canal, or geniculate ganglion. So again, looking at the CT scan will give you an idea of where you are when you are drilling. The distance also that you have between cancellous bone or pneumatization on the cochlea is the best way to have an idea of where is the cochlea. It's more precise than the neuronavigation. Descent of the superior semicircular canal, it's very rare, but it can happen. Positioning, I use supine position now, 80 degrees rotation. You can use a table to rotate more or less. Question mark incision, monitoring is mandatory. I don't think it's reasonable to do an anterior petrosal approach without monitoring 7. If you have the option of monitoring, MEP depending on lumbar drain, I have stopped using it because when I was using it, I had more seizure. I believe that the CSF is a protection for the brain when you retract extradurally. And when I was using it, I had more seizure during the surgery. So rotation is important to consider according to your target. I rotate depending on where I want to go. If it's more a petrosapex tumor than petroclival, I'll rotate more. Soft tissue dissection is important because it can bring some morbidity. So interfacial dissection to retract more the skin anteriorly without injuring of the frontal branch of the facial nerve. Retrograde dissection of the temporalis muscle. I don't remove the zygoma on the bone flap, temporal bone flap, classic one. Elevation of the dura is an important step. You peel from back to front. You need to be careful with the traction from back to front on the dura because you can injure the geniculate ganglion by tracting GSPN away anteriorly from geniculate. It's my only facial nerve palsy related to the approach that I had because I tracked it too much from back to front in a descent geniculate ganglion. And progressively, you identify your landmark, subarcuate eminence, middle meningeal artery, foramen spinosum, and foramen ovale, which is a little bit anterior and medial to spinosum. GSPN, I identify GSPN using the neuromonitoring stimulation. You start with 1 milliampere, you find the nerve, and then you move backwards toward geniculate, get more precise with lowering the intensity of the stimulation. So first you cut the middle meningeal artery. Once you cut the middle meningeal artery, you can go backward again to peel the dura from GSPN. Again, GSPN is not always easy to identify. This is what stimulation is important. It's not parallel to the ICA. There is 5-10 degrees angle with the ICA. The ICA is going more medially. And again, be careful with traction, elevating the dura from GSPN. I use a mix of peeling with a dissector and sharp dissection. Here, it's a dissection that shows you several bundles of tissue. Where is GSPN? It's not so easy to identify. And here, definitely, stimulation can be helpful because you always have a little bit of dura mater, fibrous tissue still attached to the bones that really can look like GSPN. Remember that there is sometimes significant hemorrhage and bleeding, venous bleedings that can obscure the surgical field. Once you have identified GSPN, you go towards foramen ovale and you start to peel the dura from ovale. Why do you do that? Because when you tract on the dura, you don't want to tract on V3. So you need to separate the dura mater that you will tract from V3 that you want to keep in place. Again, I am not using retraction anymore. I am using dynamic retraction and stitches, trying to have an homogeneous retraction, keep the CSF inside because it's a protection. On crossing suction and drill, you can definitely have a nice access to the petrosapex and progressively on roof without self-retaining retractor. The drilling zone, once it's exposed here, that's structures that are behind the bone, but you need to have an idea of where are those structures. So GSPN, you see it, carotid, you don't. It's not bulging medially like in the cartoon. And there is much less extent of the carotid artery medial to GSPN, but it gives you an idea. You don't see the internal auditory canal, but it's usually along kind of a vertical line. 60 degrees with GSPN, and the semicircular canal below arcuate eminence. There is not always a correspondence between both. I start the drilling here medially, then I move laterally towards carotid, then I move back to petrous dura, then I go along the internal auditory canal, go towards the fundus, and I stop when I see ivory bone. Depending on the pathology, if I need to go very far down, then I take more risk with the cochlea. Sometimes I unroof the labyrinthine segment of the facial nerve in order to have a better idea of where the cochlea is. And you can also drill the postmeatal triangle sometimes, depending on the pathology again. For cavernoma brainstem, I think it's useful. For some petroclival also, definitely when you do a combine. And 7 is the true petrous apex. Sometimes you need really to drill below Meckel's cave, which also allow you to transpose V3 between cisternal segment and extradural segment down to work above 5. The level, the depth of the cochlea is something I am always looking at on the CT scan. If you know that there is 4 millimeters between the surface and the cochlea, it's the diameter of the diamond burr. So you can go that you can dip 1 diameter of a diamond burr below the surface before reaching the cochlea. Important things to know. And according to the position of geniculate, according to the amount of retraction you have, most often it's very hard to hit the cochlea. And if you hit the cochlea, it usually means that you may have injured geniculate ganglion before. So all this, again, it's important to look at it on the CT scan. Postmeatal drilling give you more exposure to the middle cerebral peduncle. Once the drilling is done, you incise the dura, temporobasal incision of the posterior fossa dura, and then you cut the superior pectoral sinus. Depending on the pathology, I cut as medial as possible to preserve the drainage of the superior petrosal vein. And then you cut the tens towards the free edge. Be careful not to go too far back, because sometimes if you go too far back, you don't find the incisura, you cut behind. And if you go too anterior, you have a risk with 4. And then you expose the exit zone of 5. You have this beautiful view of the brainstem, and you can extend the incision anteriorly along V3, opening Meckel's cave. There is some morbidity. We have looked and just published 50 cases in GNS of our anterior petrosal approach. There is not so much approach-related morbidity related to the nerve. As I said, 1/7, because I was tracting too much on geniculate. But you may have seizures. You have to be careful with the temporal lobe. You can have dry eye if you injure GSPN. And if you have a V1 injury during the case, because it's a petroclival, you can lose the eye. So it's a significant approach for which approach morbidity is important to consider. There is more approach-related morbidity with meningioma, because you lose your landmark because of infiltration of the bone dura by the tumor, which make it more complex to find the structure to open the dura. There is no correlation in our theory between the amount of bone drilling and the approach-related complication, but still you tailor to what you need. And there is a correlation between the extent of resection, which means that sometimes we push more far the anterior petrosal approach, not necessarily for the bone, but the entire exposure, and this increase the morbidity. When you push the limit, maybe it's time to stop or to use another technique such as endoscopic endonasal. I just show you one case. This was a cavernoma, but I am running out of time. This was a petroclival that was growing. To me, it's a good case for anterior petrosectomy. I did this case because it was growing. We did angio in those tumors and uncoiling, embolization depending on the feeders. Here is a CT scan. You see how deep is the cochlea. And first, there is pneumatization above. So if you get to the pneumatization, you know that you have about 3-4 millimeters until you reach the cochlea. So here is the approach. 49 years old lady. That's a bone flap. You flatten here the bone to be as basal as possible, drilling here below temporalis muscle. You need to drill anteriorly because you need to have an access to ovale and also V2 to be able to peel the dura sufficiently to have enough exposure. This is a peeling of the temporal fossa floor. Here, progressively, I am looking for middle meningeal artery. You follow the arteries that you see on the dura. You follow them medially towards foramen spinosum. And then I go backward again to look for GSPN. And again, from back to front, if you go from front to back, you can peel GSPN from the bone and take it out from geniculate ganglion. Here is a peeling of the dura from V3. It's usually bleeding a little bit with those hemostatic agents. You can easily control the bleeding. And I am peeling the dura enough to expose Kawase triangle. You want to peel sufficiently in order to avoid traction on V3. And progressively putting some stitches, 2-3 stitches with some traction, you can expose sufficiently the petrous apex and start the drilling. Petrous ridge needs to be identified. This is here the final section of the dura next to V3, and here is Kawase triangle. I start the drilling medially. As you can see here, I use diamond burr, never a cutting burr when you do an anterior petrosectomy deep like this. Diamond, sometimes core diamond, but you have to be very careful. Here is a carotid artery on GSP anteriorly, and here I did post-meatal, pre-meatal draining. The transition between posterior fossa dura and internal auditory canal, you have to remember, is smooth. It's not like you have a sharp angle between posterior fossa dura and the beginning of the dura of the anterior aspect of internal auditory canal. It's really a smooth angle. Coagulation of the dura is coagulation of the dural base on feeders. Here I am opening the dura, opening the posterior fossa dura, and you will see that the meningioma is not bleeding so much. Don't remember here if I could preserve the petrosal vein or not. I am cutting here the dura and the tentorium and superior pectoral sinus. Sometimes I just coagulate, sometimes I use clips, sometimes I stitch, it depends. And then once you have connected both, you have a very nice exposure on the petroclival meningioma, and you can see 5. 5 is pushed up and a little bit laterally in this case. And you can follow 5 into Meckel's cave, opening Meckel's cave anteriorly. This is the beauty of this approach, is that you can resect the part of the tumor that is also infiltrating Meckel's cave. 6th nerve is the difficult part. For those tumors, I try to find 6 in the CP angle below the tumor. It's not always possible. If to find it medially, you have to work slowly. It's difficult. It's difficult, and sometimes you just need a little bit of luck not to injure. Sorry, yeah, I'm done. Huh? Yeah. That's the final exposure. And here with the endoscope, I just check the Dorellos canal entry zone. I don't want to injure 6. So for this final part of the resection, I do it under endoscopic control, leave a little bit of tumor around the 6th nerve to preserve it. Okay, I skip this one. It was a chondrosarcoma. And I go to my conclusion. It's an important approach in skull-base surgery. There is a lot of indication. So it's an important approach for skull-base surgeon. Anatomy is extremely important, but it can be an approach with some morbidities that needs some training in the lab. Thank you very much for inviting me, allowing me to speak, and Fred will stay with me.
Thanks.
Thank you very much.
Thank you. Think we probably have lost some time here. Unless someone wants to make any comment or any questions from the panel. I think there may be one. There's nothing in the chat. So anyone to comment? Fine. I think we will move on. I will ask my co-moderator, Professor Igor Maldonado, to start the next session.
Thank you, Ramesh. So it's my pleasure to call the next speaker, Professor Luciano Mastronardi, to give his lecture on the utility of endoscopy in acoustic neuroma surgery. Please go ahead, Luciano.
Good afternoon. It is. I hope you can hear me. Can you hear me?
We do.
Yeah, thanks. So it's a pleasure and an honor for me to be inserted in this outstanding webinar in honor of Professor Fred Gentili. I knew him. It was a very nice person and a giant of neurosurgery. So in memory of him, I prepared this my lecture of today, the utility of endoscopy in acoustic neuroma surgery. And the key points of vestibular schwannoma microneurosurgery in my setting are the Fukushima lateral position, keyhole opening and micron technique, CSF aspiration in the lateral medullary system. Then I try to do a clean, bloodless, and sharp dissection anytime, maintaining the arachnoid plane. Sufficient internal tumor debulking is very important, especially large tumors. Then we have to identify the fascial nerve. Usually I use the monopolar stimulator. And then we have to do a final capsule elevation with a BCAT technique, I'll show you later, and preserving artery and veins, and of course, preserve a normal face. This is our study updated to March 2022. We collected 300 consecutive cases of vestibular schwannomas. In majority of cases, the tumor was grade 3 or grade 4, and the mean age was around 50. We obtained the normal fascial function, HB1, I mean, at 6-month follow-up in more than 90% of cases, especially when the tumor was, when fascial was in ventral superior or ventral inferior position. The worst position for the result seems to be the ventral position. We had some cases in which we attempted a hearing preservation, and we succeeded in 99 cases selected. We obtained the result in 61% of cases. So this is the position we use, the Fukushima lateral position, but you know there are many other positions. In particular, the sitting position I don't use for several reasons linked to my anesthesiologist. But anyway, this is a matter of training. So this is the summary of our results. Majority of cases we obtained after 6 months, 90% of HB1 function. Socially useful hearing preserved in more than 50% with AA, OH, and S, A, and B preoperative function. Then these are the other data related to the surgical skillness. So these are the instruments we normally use it for microneurosurgery of vestibular schwannomas. We use several micro dissectors, micro scissors, curettes, and many other micro instruments. Then we use, of course, the neuromonitoring, especially in fascial nerve intraoperative stimulator, ABR, for hearing preservation. Then we use the electrode in the tube for the monitoring of the lower cranial nerves. Then we use other instruments like the sonopet ultrasonic aspirator, fiber laser, and finally, the topic of this lecture is the intraoperative final check of the internal auditory canal with the flexible endoscope. Very quickly, this is our opening. We do more or less 3 square centimeters of opening, exposing sigmoid sinus, a transverse sinus. Then we open the dura and immediately search the laterally medullary system in order to obtain a detention, immediately CSF aspiration and detention of the cerebellum, and then opening the dura. Then it starts the true approach to the tumor, maintaining the arachnoid plane and trying, especially in a small tumor like this, to locate immediately the fascial nerve, in this case in inferior anterior position. We use the stimulation, monopolar stimulation in all cases as a nerve detector instrument. Then this is the first article we published for describing the possible position of fascial nerve in different cases, in majority of cases, in about half of cases, the tumor was anterior superior, 1/3 and ventral, anterior through, and 20% anterior inferior. So we start with 1 milliampere on the surface of tumor. Then when we are close to the nerve, we reduce to 0.5, 0.01 milliampere. This is the VUCAT technique that we did at the beginning with the scissors. Now we do with the laser. This is for identification of the capsule of the tumor. And an important step of this procedure, is the opening of internal auditory canal. We use with two main instruments. I mean, with the both laser and the diffuser. This is again the identification of facial nerve. Then the laser tooling is used for opening the dura that cover the internal in the meatus,
in order to detach it and gaining access to the roof of the internal.
And then we go on with the sonopet and opening the internal auditory canal. Then with other micro instruments, we remove the part of the tumor inside the canal. And this is the final view after the removal of tumor, the final evaluation of facial nerve. A little bit different is the technique for the large vestibular schwannomas, though in all these cases we do generous internal debulking of tumor with several instruments. This is our article of 60 cases. Of course, the results of facial nerve is not the best, particularly in a tumor with a capsule very adherent to the nervus and the hypervascular tumors. Even if in the last years we had better results, in 93% of cases we obtained at 6 months HB1, HB2 result. This is the video that we published on World Neurosurgery for the endoscopic control of the internal auditory canal. I just skipped this part that I showed you before. This opening we do partially with drill and partially with sonopet. Opening the canal, and then with the laser and other instruments, we gradually remove the tumor inside the canal. Hooklets, the incurettes, or the forceps. At the end, it seems that we removed all the tumor, but in order to be sure, we prefer to open a little bit more with the sonopet and then introduce at the end the flexible endoscopic assistance in order to see the fundus. And we discovered some residue of tumor and all the nerves, of course, and then we are able to locate this small residue of tumor and remove with the hooklets in a safe way. And then the final check confirmed the total removal of tumor that the MRI confirmed. Then we tried to compare the use of flexible endoscope and of rigid endoscope. Surely the quality of the endoscope is different. In this case, this is a flexible endoscope showed the residual, small residual of tumor that we could remove. And it's easy to handle. We can enter inside the internal auditory canal very easily and have a look at the fundus. For sure, the quality on the right side of the rigid endoscope is better. Anyway, is in my hands much more difficult to handle inside a small space of 3 square centimeters. So I prefer to insert during the microsurgical procedure under the microscope. View the flexible endoscope and have a look in the fundus. And in both cases, we can see that this is the same case. We had a look of the fundus and some remnant of tumor. This study confirmed that after the insertion, after the starting to use of the endoscope, we had an improvement of the results. So we have in all these cases presented 32 cases are total or gross total or near total removal in comparison to 1/3 of subtotal removal of microsurgical resection only. So this small part of tumor remnant in the fundus now can be discovered and removed. Much more important is that, I mean, it's also important the use of endoscope for discovering some small air cells opening in order to avoid the post-operative fistula and the renal leukorrhea, so we can occlude them after checking much more completely. So in conclusion, vestibular schwannoma usually requires surgery. The total and nil-total removal preserving facial nerve function is usually possible, and socially useful hearing can be preserved if the diameter is less than 2 centimeters and the preoperative hearing is quite good and serviceable. At the end, endoscopic assisted microneurosurgery can cure vestibular schwannoma. Thank you for the attention.
Thank you, Luciano. Very interesting lecture. Thanks for keeping on time. Any questions? I don't see any questions from the chat. Any questions from the comments from the panelists? Could you please develop a little bit this checking for CSF fistulas? Do you think you've already seen some changes in your practice?
Yes. Yes. I have to be honest. It changes a lot. I mean, in the past, we had, of course, very seldomly, but we had some renal leukorrhea that we could not explain so well because we closed all the air cells we could see, and we, as usual, we do a nice job. It's not nice to say, but anyway, we try to occlude any cells. But time to time, by fortune, very seldomly cases, we had some renal leukorrhea we could not understand. Now, after the use since 6 years, about 5-6 years of this technique, we had a reduction, a clear reduction of this problem. I mean, very, very, very seldomly, much more seldomly than before, because we can see if there are some bone cells, I mean, open it and we can close much more completely. That is my experience. Yeah.
So if you understood well, it became something systematic in your practice.
Yeah. Exactly.
Yeah. Okay. Thank you. Any more comments? Oh, thank you, Luciano, for your
welcome. Welcome. It's an honor. Pleasure.
So let's move to the next speaker, Professor Keki Turrell. I don't see Professor Turrell and the panelists.
Yeah, I can't see him.
Keki, are you there?
I don't think
see him. I saw Professor Landero was there.
I think the net connection. Hi, Jose.
Professor Landero, nice to see you. You are muted. Are you going to give your lecture then?
I think the internet connection apparently is not very good. So.
Oh, okay. So I can't hear you, Landero. I think you're muted. Unmute your microphone.
No.
Igor, Professor Landero has sent us a communication. I mentioned to Ramesh. He won't be able to yield his lecture because of the connection. He is attending, but he's unable to talk. So this is the reason he excused himself from giving the presentation.
Okay, so it means that Professor Mastronardi lecture was the last one. So let me switch to Professor Benes for the final comments and discussion. Vladimir. I think it's the end of the session.
Well, it seems Vladimir is not there, so...
Yes, I am, but I gave you precedence. Okay, I believe that we all enjoyed ourselves. The lectures were excellent, and I'm extremely happy that we've had she's not anymore with us, but it doesn't matter. Thanks for joining us for the session. And we all probably should thank Imad that he put together this event and that he organized all of us to talk, and that he really has spent quite a lot of time getting everyone together. And I just can imagine how many mails and how much time all this cost him. So Imad, thank you very much. And I think that it's up to you to conclude the session, and it's up to you to invite us for the next one, I guess. Imad, please.
Well, thanks everybody for your contribution. It was a marvelous session. We learned from each other and from the experts as well. It was wonderful, and the discussion was really very nice. And I hope we will reconvene again in the future. The next webinar will be in 2 months, and it will be in recognition of Professor Touré, who is one of the seniors of this academy. He has contributed. Today he is not here, unfortunately, and I hope all of you will contribute. And I think in September, there will be a collaboration with the Asian, Australasian neurosurgeons, and Vladimir will conduct a course. So this is the beauty of the IANA, is not only the webinar, but we have a hands-on courses. We did one in Bogota. It was the first to have a hands-on, on-site activities. And Vladimir, you'd like to announce that the future?
Oh, yes. Thank you. Thank you all of you who has sent me the acceptance, who has sent me the lectures. There are now 19 lectures. I have compiled, I have just today sent it to Andrew Kay, who's going to send the invitation letters to every one of you. Henry, I see you that you are already smiling, looking forward to get the lecture or invitation. And I'm also promised that each of the presenters will be included into the regular program. So you will be asked for the lecture. Either it will be plenary or keynote. I do not know. It's up to the organizers. But we all will have the opportunity to present something during the actual event. And the last but not least, Pablo, are you there? He's not anymore here. We could join it with a trip, and that was Petra, which came to my mind. And as far as I know, Pablo cannot go after the Congress, so we probably could go 2 or 3 days before the Congress. So let me know who would be interested, and I shall check the opportunities. So see you in Jerusalem, but see you first during our next webinar. Thanks for joining us.
Thank you.
Thank you.
Bye-bye.
Goodbye.
Bye.
Bye.
Bye. Jose, thank you for the receipts.
For the what?
For receipts, because I didn't have the receipt from the hotel and from the Congress for the fee.
Sure.
And my accountants nearly killed me.
Yes, Paula solved everything.
Everything's
Okay.
sorted. Jose, thank you.
Bye-bye.
Bye.
Bye.
Bye-bye.
Bye.
I was very moved with this. Thank you.
Bye.